Okay, well, good morning, good afternoon, good evening to you all, wherever you are in the world joining us today. Firstly, I just wanted to say that in these strange and weird times, we're generally overwhelmed by the support we're getting from you all. We've literally had hundreds of people register for these seminars over the next couple of weeks. So thank you for the trust you've put in us. I know most of you have, but we just ask that we kindly put your Zoom or your laptop on mute, just to keep down the background noise. Also, no need to have your cameras on, but you're more than welcome to do so if you want. But if you've got a beer in your hand that you want to hide, then no problem in doing that. I'm just going to make a few introductions and just give you an overview as to what you can expect over the next couple of hours. First of all, my name's Simon Porter. I'm the marketing manager for Orthomed. I'm based in the north of England, which is where our international head office and warehouse is. Today's lead speaker is Bruce Wadicki. He's an ACVS boarded surgeon. He's based on the east coast of America, over in Maryland, and where he owns his own referral centre. And I'll let him do his own introduction just before the presentation starts. We're also joined by Sarit Duper, again another ACVS boarded surgeon, and he's actually the clinical director both for Orthomed and for Infinity Medical, and he'll be giving his own thoughts and views and ideas, most probably towards the end of the presentation. Also, we've got Charles Achonya. Many of you in America and Canada might well know him. He's our sales manager for the North America area. So just to give you a brief overview of what you can expect over the next couple of hours, it's an accumulation really of the frequently asked questions that we've been collating over the last few years. We're going to discuss the evolution of the MMP procedure over the years. There's a few changes that you might have missed, but we've also had some updates to the equipment and also to the implants. So we're going to update you with all of that. Bruce is going to talk about his experiences and discuss some of the challenges and the complications that he's come across over the years. But most importantly, he's going to talk about what he's learned from it. He's going to pass on some advice, some hints, some tips, and also to reassure you as what you can do should you come across any similar situations pre, during, or after surgery. We want you to leave this session today feeling reassured that like any other surgery, MMP does have its challenges, but none of them are insurmountable, and we don't want you to be scared by them. We want you to go away feeling empowered to take this on board. And we're not going to shy away from any topic today. We're going to really hit it head on, and you're going to see a lot of case examples of MMP. One of the most important aspects, I think, today is the interaction that we get from you. And like I said, we want to be transparent about MMP. So a lot of that will come from questions from you all. And within Zoom, there's the opportunity, there's the availability to chat and to ask questions. And we want to keep it anonymous as possible. So today, I'm going to play moderator. And if you go to the chat section and you look for my name, Simon Porter, I'll be making notes of all the questions and everything that comes through. And then towards the end of the presentation, we'll put these to Bruce and Sarit, and like I said, we'll keep them completely anonymous. We've got a really good mix of people here today. We've got frequent users, occasional users, maybe some surgeons that have lost a bit of confidence with MMP over the years, and some people that are just learning about MMP for the first time. And in this new remote world that we've got, we're really happy that we can actually bring back MMP workshops, which over the next few months we're going to put in place so we can do these remotely, and also offer the practical session. So whether you want to come on a refresher course or you want to learn about it for the first time, we will keep you updated with the dates of when we're going to start running these MMP workshops again. So that's quite exciting. Just to let you know as well, we're going to record this, so it will be available for you afterwards. And that's it really from me. No more waffle. Like I said, any questions you have, send them direct to Simon Porter on the messaging service. I'll make a note of them, and we'll talk about them at the end. So enjoy the next few hours, and Bruce, I'll hand over to you.
Good. Thanks so much, Simon. Can everyone hear me? I hope. Yeah. So my name is Bruce Wadike. I am a small animal surgeon based in Maryland now. I was at the university at North Carolina State University for a few years after residency, and then got bitten by the bug in private practice and haven't been back since. But I still love a bit of teaching, and the time that I've spent now working with Orthomed has got me back into that realm a bit. I started using Orthomed's equipment back in 2011, and have had some time to use it, figure out what things, as Simon said, work really, really well, and what things I thought we can potentially improve. And Orthomed's been really, really good at receiving feedback and working with not only myself, but other practitioners as well, giving the feedback. So in the last 2 years, I've joined on as a lecturer and presenter and surgeon advisor for Orthomed, teaching the workshops, and that's really given me another different perspective as well. So I'm happy to be along, and honored to have had this opportunity to work with them. I do hold no financial interest in the sales of its products or equipment, and thank you for being here. So in the way of just a very quick update as to where we are numbers wise, MMP is being performed by veterinary surgeons in 32 different countries around the world, 5 different continents, and to date, more than 50,000, 55,000 wedges have been sold. So it's quite a popular product and procedure, and gaining more and more interest as time goes on, evidenced by all of you who signed up for today and are here visiting. A few changes occurred over the years since I started back in 2011 with the equipment. The standard and medium breed kits were put together as one, since they share a number of equipment together. It made sense to put the two and give you a little bit more versatility while you're operating with respect to different shapes of bones. This 2.5 millimeter sleeve is common to the two kits, the small breed and the standard medium breed kit, and that allows you to downsize your Mackay drill hole size to 2.5, and in order to change the stress concentration at that hole as you do your hinged area at the distal tibial tuberosity. Additionally, the previously used carbon fiber type trial wedges has changed and become the metallic ones, which in the kit are, as I said, both medium and large, as well as the small double-sided now. With respect to preoperative planning, still utilized radiographs as an initial planning tool. Can't do the procedure without some sort of planning, even though the different techniques for determining tibial tuberosity advancement are sort of all over the map, and we'll touch on that. But start with standard orthogonal views, give us exactly what we need to see in the limb, looking at the bone integrity, the features inside the joint that are consistent with ligamentous instability, and more importantly, looking at the conformation, the shape of the bones that we're dealing with. 135-degree angle is not absolutely necessary, but if you can get just a routine standing angle on your medial lateral view, it's very helpful. Most importantly, having some sort of calibration marker placed close to the stifle joint is really important for us and myself, as well as the other advisors, providing you with some feedback if you happen to submit radiographs, and also for yourselves, to get proper measurements on these images to make sure that they're well calibrated, properly calibrated. So as close as you can get them to the stifle, even better. And there's several different types out there. There's the metallic sphere on the articulated arm that's showed up here. And these are really nice to flexible bending, get you directly where you need to go. And then there's the old style through biometrics that has the 10 centimeter markers on that block. So definitely helps. And what we take from this information with respect to planning initially is, as I said, looking at the conformation of the bone, the insertion point of the patellar tendon, the overall shape of the proximal tibia. And our plan is to aim for, at the proximal aspect, starting at the point of the tibial tuberosity, 8 to 10 millimeters in thickness of that proximal tibial tuberosity. We want to start our osteotomy caudal to the patellar tendon, parallel to the cranial tibial tuberosity cortex, and get lengths that are somewhere in the 20 to 40 range, depending on what size implants you're going to use, so that your tibial tuberosity length can be measured from this radiograph as well, to give you some idea as to what size implants you're going to use, what system. And that's important because one size doesn't fit all, as we can see from these two images. So proper planning ahead of time really does make a huge difference. And so we're going to go through some more detail about how that planning can be assistive to you before you even get into the operating theater, which makes a massive difference for cutting down on time and eliminating problems and complications once you're in there. So tibial tuberosity thickness is governed essentially by not only the shape of the tibia, but what you control, which is the angle of your osteotomy. If you don't plan the angle of your osteotomy appropriately, you're going to end up with problems, not only just too thin a tibial tuberosity sometimes, if you sit too far cranial, if you come in at a very sharp angle based on how you put up your distal pegs, too thick, you can come off the front of your tibial tuberosity at a sharp angle and end up with a very, very thin piece of bone or short piece of bone. If you angle caudally into the weight-bearing axis of the tibia, you end up with too thick distally, too thin proximally, and potentially increase your risk of fracture. So it's really important to try to get that parallel to the cranial surface of that tibial tuberosity and outside and away from the long functional axis of the tibia. A little bit more detail. I like to measure the proximal aspect and mid sort of tibial aspect to ensure that I'm getting an appropriate thickness. And that has been shown in some work that looked at risk factors for tibial tuberosity fractures. If we can get our tibial tuberosity thickness around 25 to 30% of that craniocaudal tibial depth or thickness, that is an ideal dimension to work with to prevent, well, to give you a good working thickness to put implants into, as well as to prevent some potential complications with respect to fracture of the tibial tuberosity. So approximately 8 to 10 millimeters, and I actually measure this thickness on all of my patients across from cranial to caudal and see what that 25 to 30% works out to be. And the same thing distally, a short distance down, not all the way down to the distal end of your tuberosity, but somewhere in that mid thickness to determine and measure both of those, figure out what works for you, for that patient. That comes up with two specific points that reflect those two measurements. And then we align those 2 points with a point just approximately starting behind the patellar tendon on the tibial plateau, connect those 2 points, and that's your proposed osteotomy line, right? So want it parallel, as I said, to the cranial cortex, and importantly, when the Mackay hole is drilled, we want to end up with, depending on the length of your tibial tuberosity and the size of the system that you're using, somewhere between 24, 34, or 44 respectively to accommodate the small, medium, or standard wedges. And that extra 4 millimeters beyond the length of the implant accounts for 2 millimeters proximal and 2 millimeters distal to where your implant is going to be sitting. So 2 millimeters distally above the Mackay hole and 2 millimeters proximally, so that your wedge, your implant, sits dead center within that osteotomy gap that you've created. And that bears a lot of information that can be gleaned from what the shape of your osteotomy will look like depending on where you begin your osteotomy proximally and end up distally. So clearly, if you start too far cranial, you're going to end up with a very thin segment of bone. If you start very caudal, you end up quite thick and exposed cancellous bone. And that bears in mind what happens with what sort of bone your implant will sit on. We like it to sit on good cortical bone, bridged on both lateral and medial cortices, so that there's very little room for subsidence into that soft cancellous bone. So we try to not end up too far caudal here with a very sloped osteotomy. Instead, 2 will be ideal where it's parallel to that cranial cortex, as I mentioned. So how much tibial tuberosity advancement is needed? Essentially, what size orthofoam wedge is to be selected? What we do know is that the conventional TTA methods for estimating that advancement, they seem to be inconsistent, unpredictable at best. It's nice to still use it to have some idea as to what's out there, but each of them has their own potential flaws, and each technique doesn't give us a repeatable outcome with respect to desired tibial tuberosity advancement distance. So we do know that the technique works. This paper by Ramirez and others in 2014 showed that pre-tensioning that patella tendon leads to stiffness in a direction perpendicular to that applied tension, and that opposes that tibiofemoral shear force and cranial displacement of the tibia. And that bears in mind the degree of essential flexion that's built into the system when based on TPA measurements less than or greater than 23 degrees. Orthomed has contended that when we take all of the information that's out there with respect to planning TTA and how much advancement is needed, that trying to simplify the technique and utilizing a selection that's based on the stature of the patient, not the patient weight, but the stature of the patient, which takes into account the shape and dimensions of the proximal tibia, seems to be a lot more consistent to apply across the board, so that many more practitioners can utilize this technique, utilizing our charts that we have come up with. So it simplifies the MMP procedure significantly in so doing. It's still not perfect. There isn't a perfect system out there. There are some potential risks for either under-selecting or over-selecting a wedge size. My rule is that when in doubt, go up the extra 1.5 millimeters if you possibly can. And that may be a bit more critical in the very small breeds, where going up 1 millimeter may make a huge difference and actually over advance the tibial tuberosity. But there are a little bit of wiggle room for each one of these to allow. And one of the things that I routinely do is when I have the trial wedge in place, I always test for cranial tibial thrust to see if I have abolished that cranial tibial thrust. So I test cranial tibial thrust before I make my osteotomy, ensure that I see that it's present, and then when I place the trial wedge in place that I desire, if I still have cranial tibial thrust with that particular trial wedge, then I'll pop up to the next size. And that's something that I've been doing fairly routinely, and it seems to work really nicely. And So the different breed sizes are there, and the selections that are there as well. It is possible to do some intraoperative planning based on those two measured points on your radiographs as well. And this is one of the techniques that I've started teaching and adding to my own surgical procedures to get much more consistency and repeatability with my osteotomy of the tibial tuberosity, to make it uniformly thick and based on planning. So you can translate those two measured points to the actual tibial surface, measuring these on the radiographs and then translating those same 2 points onto the bone intraoperatively. So using these Castroviejo calipers, you could get them on eBay for $9, $10 each, sterilize them by steam, and they hold up really, really well. Since they're not metallic implants, they don't need to be surgical grade for implanting, and the less expensive ones online are quite reasonable to use over and over. We've been using them for years. And insert 0.9 millimeter K-wires at each of these 2 points. You can see those K-wires represented there. Corresponds to the same 2 points that are there. And then you can slide that saw guide right over the top of those K-wires so that the K-wires are positioned within that cutting channel. In the osteotomy channel, now essentially with the proximal peg in place behind the patella tendon and sitting right on that proximal slope of the tibial tuberosity, we do see that we get a perfect parallel alignment of the osteotomy channel, the proposed osteotomy channel, guided by these 2 K-wires. It is not absolutely essential, but it's a nice thing to have as an option, especially in patients when you're sort of not entirely certain where your osteotomy is going to line up. This is something that gives you a little bit more repeatability. In this particular patient, I've left off the distal peg, and that distal peg sometimes may cause this, depending on the thickness that you choose, can cause the saw guide to be pulled too far cranially or to be too loose. And in giant breeds, I always leave them off because of the length of the tibial tuberosity. If you put on the peg, it may artificially pull your saw guide cranially, and you end up with a bit of a diagonal cut. So governed by these K-wires, even inserted monocortically, they seem to work really well. And then it allows you to have access to your Mackay hole to put your drill bit through. So whether you're using the medium, small, or standard, you can put your Mackay hole or drill sleeve down in, the drill bit or the drill sleeve with the drill down. The next thing I do is I pop that in and I lift with the drill in place. I will just lift it off the bone slightly just to ensure that my Mackay hole is going to be properly positioned with these 2 so that I know that my measurements are appropriate. To try to get these measurements a little bit more specific, sometimes if you'd like to take a hypodermic needle and just walk off the edge of the bone and just let it sit into the soft tissue, and then the calipers will go from the point of the hypodermic needle back, and you get a more accurate measurement. And that's what it looks like when it's sitting in the channel. So you have clear access to that Mackay hole, pop your drill bit in or your drill sleeve and drill bit in, slightly lift this up, assure that you like the position of your Mackay hole. It's not too far caudal that you're too thick distally, and it's not too far cranial that you're going to be too thin and falling off the edge of that. And you can make adjustments accordingly to your measurements. Once you're happy with that, pop in your Mackay drill bit, remove your K-wires, and complete your osteotomy routinely, making sure that you irrigate. All right, so it's a nice way to ensure that you get the appropriate parallel alignment of the osteotomy and the appropriate thickness of your tibial tuberosity. That's what it looks like here, which you're all familiar with. Pop the Mackay hole in. With the drill bit in place, it locks the saw guide, gives you a nice, consistent osteotomy parallel to your cranial surface, and then the distal isthmus is cut, completing the osteotomy. So now that we've gotten to this point, this is a way to double check that we actually achieved what we set out to. So on your radiograph, compared to the thickness of that, 8 to 10 above, 25 to 30% of the caudal cranial thickness, 6 to 8 distally, and that's also 25 to 30% of the caudal, of the thickness, cranial to caudal. Here's your Mackay hole at the distal end of your osteotomy, parallel to your cranial cortex. And that distance to your Mackay hole, ideally we like it in the standard breed, somewhere about 3 to 4 millimeters from the cranial aspect of that cortex on the tibial tuberosity. And that works out to be somewhere around the same thickness of your actual cortex, so that as you hinge at this location, as you hinge, you're hinging with thick cortical bone rather than very thin area of cortical bone. And more importantly, that your Mackay hole is not sitting back here and you've got too far a thickness and now you can't even hinge your tibial tuberosity forward at all. Very important, as I said, because one size does not fit all. So we try to get that osteotomy length that corresponds to the size of the implant that we're going for. For a standard breed, this is a 44 length of osteotomy from top to bottom that accommodates our 40 millimeter implant, giving you 2 millimeters proximally and 2 millimeters distally. And that's to accommodate, as I said, the trial wedges that determine not only gradual hinging and advancement of your tibial tuberosity, but these trial wedges will determine the final position of your implant as well. So we want to make sure that we just get it flush with the medial surface or slightly proud, and then eyeball that 2 millimeter distance distally. And I also take a thumb forceps, and I'll evaluate the proximal aspect too to make sure that I'm not too distal or too proximal within the joint. Once you're happy with that, you switch out your implants with the trial wedges, assuming that you've tested your cranial tibial thrust. Once you're pleased with that, get it properly aligned, still 2 millimeters above your Mackay hole, and then proximally 2 millimeters distal to your tibial surface, your joint surface. Right. So this is what the final result should look like, where you've gotten nice parallel osteotomy to your cranial cortex. You've got great compression across your wedge bone interfaces. Your implant is sitting 2 millimeters distal to the proximal surface, 2 millimeters proximal to the Mackay hole. Your Mackay hole is sitting just caudal to the cortical bone. You manage to preserve this distal isthmus of bone. It's not critical, but it's nice if you do. It looks great on a radiograph. And more importantly, your distal tibial fixation is secure, sitting in good bone, and your staple is in appropriate plane. In the cranial caudal view, and I'll go through these when I review how to look at radiographs, and critically, in this view, your implant is sitting close to your medial cortex, not too far lateral, dead center within your osteotomy. Beautiful image, great film. That's what it looks like here. The medium breed wedge is 7.5 millimeters of advancement and 30 millimeters in length. There is some talk of a 9 millimeter medium wedge in development. Stay tuned. Key differences between these are that we do use a different saw guide. It is smaller to accommodate the shorter length of tibial tuberosity, and the same wedge introducer is universal between the two systems as it's all combined. Most importantly, the K-wire hole is actually 2/3 the way down the wedge, and so you need to be very, very careful. You can see you don't have much distance between your K-wire and the distal end of where the Mackay hole is. So you have a shorter distance in which to place your staple. And people, oftentimes we've seen, place their staples a little bit too proximal because they're worried about where that Mackay hole is. You can see that Mackay hole. You can even take your drill bit and insert it back into the hole so that you can get a better idea of where that hole is compared to your K-wire, which you can visualize, and then place your staple 50% of that distance. The saw guide is different, as I said, with same 3 different pegs distally, and you can utilize that K-wire technique to pinpoint positioning and governing your osteotomy position appropriately if you so like. And I still start with the number 3 or the medium size for the distal peg almost routinely, and then size up or down accordingly if I feel the need to do so. Radiographic planning for these, same principle. Do a quarter to 30% of the distance craniocaudally, and do 8 millimeters for this, approximately 7 distal. Here's my osteotomy planned, proximal caudal to the patella tendon, Mackay hole right at 34 millimeters. This is the perfect size and shape for this medium breed in this particular patient. So we'll go through the medium Mackay MMP procedure for using a cadaver, just to highlight a few of those specific points as we go along. And I will talk over the top of this and narrate what's happening, so bear with me as we go. So routine medial approach, just distal to the patella itself, sort of medial parapatella, proximal tibia incision. Try not to do too much dissection, just down to the bone with your initial incision, and then your caudal patella, caudal parapatella incision just at the top of the tibia to allow your medicine balm to be placed in and pop through the lateral capsule. And that's demonstrated here. Try not to do too much dissection. It's really, really important. Trying to preserve those soft tissues. I try to only expose the bone where it's absolutely necessary to prevent taking down too much of the soft tissues, which are important for osteotomy healing and functional use of the limb with the muscles thereafter. So assessing the proximal location of that peg, and then determining the size of your distal peg, ensuring that your osteotomy channel is parallel to your cranial cortex. Insert your Mackay drill bit, and that locks and holds your implant in place. This is you can use either the 3/5 or the 2/5 for this if you needed to step down, and then begin your osteotomy. Really important during this to ensure an assistant is irrigating the bone to prevent too much thermal necrosis of your bone, which will affect your bony ingrowth into your orthophone wedge. It's really important. You see how the painting technique of sliding back and forth, going sequentially from superficial to deep in that bone is really important versus just staying in one spot and cutting and all the way down. I tend to paint from side to side so that you get even distribution of the heat, as well as sequential osteotomy down to the desired level. Once you've punched through proximally and distally, you know you've protected your patella tendon appropriately, and you should just have a very narrow isthmus of bone distally above your Mackay hole, which needs to be completed. Once you remove your saw guide, take a blade and just expose that narrow isthmus. And then very importantly, see how we start with the blade inside the channel that's already been cut. And that prevents you from creating too many additional planes of cutting. So pop it into the channel, then fire it up and angle towards the Mackay hole, trying not to go distal to it. Apply your point of reduction forceps, extend the knee, extend the stifle to get some pressure off so that you can allow your hinge to work really well to allow advancement. And it's really important to use that point of reduction forceps as a handle that helps you to lever that tibial tuberosity. Make sure you're using the medium, starting with the lowest, so the 6, going up to 7.5 finally. Usually insert from proximal to distal, going along the direction of that wedge shape, ensuring that your distal end of your trial is not too far proximal, and more importantly, that you don't drag any soft tissues in with you. Flip over and go to the 7.5, inserting the same principle. Sometimes that soft tissue on the far side inhibits your ability to fully advance, so trimming some of that soft tissue away is necessary to accommodate the final size. So see how much easier that popped into place. Again, making sure no soft tissues come in. And once that's in place, now I can test my tibial tuberosity. Advancement has abolished the cranial tibial thrust by popping it back into extension and doing cranial tibial thrust manipulation. Now we should be able to switch out for the appropriate size, which is a 7.5 wedge. And I recognize some of this is redundant for you, but it's nice to see it again, fresh in your eyes after some time. Sort of, if you're not reviewing these every time you do your procedures, it's important. Because probably the most critical step is placing the point of reduction forceps across the bone wedge interface in order to establish pre-compression. That's the single most important step, because any distal fixation that's done now is usually just holding whatever pre-compression you established. So this is no K-wire technique. So now with the knee inflection and the point of reduction forceps applied, we're going to place a staple distally, beginning 50% the distance between the proposed K-wire and the Mackay hole. Must use this drill bit, and I'm sorry, the drill guide, and make sure that it's held flat against that bony surface. And sometimes just elevating your limb off the table allows you to get perfect position and flattened against that surface. The cranial hole is bicortical, and there's a small peg that fits into the drill guide first hole, goes all the way through, and that allows that drill guide to be used appropriately to determine where your next hole is going to be. So you have two different sizes, the standard versus the small, and for this patient, the small seems to be appropriate, avoiding the caudal cortex, sitting flat against the bone. This is a monocortical hole that's drilled. Now just pop through the cis cortex. And then a nice thing to do here is to pop in a K-wire into that hole that you just drilled prior to removing, because when blood fills that hole, it gets a bit difficult to find your hole, and you have to suction in between. These staple holders and placement guides really do help to hold that staple in place to allow hammering and knocking it into position as well, with a little bit broader surface to hit. Really important to make sure that you're inserting that staple perpendicular to the surface. And I've had some people ask whether or not you can use a mallet. I've seen people use mallets before, and they actually can create some fissuring or fracture with that technique, and I prefer to not do that. So that's the medium breed. For the small breed wedges, 20 millimeters in length, and starting at 3 all the way up to 8 millimeters with 1 millimeter increments. And you can see that there's a lot more variation in the size of the tibial tuberosity in smaller dogs and the shape of their tibial tuberosity. So really important for planning. With the small breed kit, it's a completely separate kit with small sized everything in here. Not only the saw guide, but which is potentially oversized for the size of the patient sometimes that you're working with. There's some 3 proximal and 3 distal pegs in order to determine what's the most appropriate thickness of the implant that you're working with. And I say that the proximal peg, I usually go with either the thinnest or the middle, and then I usually start with the thickest distally and then move to the others thereafter, just as an initial size. There is some trial and error just sort of to get used to it, but you can also use your that K-wire technique for this as well. The wedge that you put in is actually thinner medial to lateral, so not only is the tibial tuberosity thinner sometimes because of these little toy breeds, but the implant's also thinner. So it's really important to not make your osteotomy too caudal, and then you've got too much exposed cancellous bone, because you will get broken wedges a lot easier with these because the pull of the quadriceps is still pound for pound. The forces are pretty high in these small dogs as well, regardless of their size. There is a different wedge introducer and butterfly guide as well. The important thing about the butterfly guide is it only fits in one direction with its 2 holes, and we'll see that in the video. There is a step down size sleeve in order to put the 2.5 millimeter drill bit as well. So radiographic planning, very critical in these little guides. You can see the shapes and the morphology of their tibial tuberosities are very, very different. Some of them have profound caudal tibial plateau slopes as well. And so this all factors in. So we still measure proximal and distal and try to go for 25 to 30 millimeters, 25 to 30% of that distance for both of these. So look at that, distal end is 4 millimeters in this particular patient. So trying to fit a distal fixation is going to be challenging with only 2 millimeters to work with if you're trying to go in the middle of the bone. So if I measure that tibial tuberosity length, it comes up to 16 millimeters in this particular patient. Really, really short compared to the length of the implant, which is 20 millimeters. So we do need to accommodate that. So we have to make up for that extra 4 millimeters by moving our osteotomy a little bit more distal to the end of our tibial tuberosity. Beautiful thing is that in this particular patient, we're still left with some thick cortex to work with. If I were to add that extra 4 millimeters that I've discussed to accommodate the placing the implant dead center with allowing 2 millimeters proximal, 2 millimeters distally, you can see how far down that tibial shaft we end up, and now we're getting into the long axis of the tibia and its primary weight bearing axis. So for this patient, I will eliminate that extra and cut this osteotomy short at exactly 20 millimeters and plan to put the implant flush after my osteotomy with the proximal surface rather than sinking it down the extra 2 millimeters. So it's really important to plan these accordingly. So for the small, we'll take a look at the video and go through similar to what was done before. Understanding that you've just seen the medium. So here we are, we already made the approach. And as I said, there are multiple different sizes of the distal peg and proximal pegs. Trial and error to make sure. And what we're looking at is aligning the osteotomy to be, look at the channel and ensure that it's parallel as you pull disc. See how that osteotomy is going to be parallel to your cranial surface. Insert your 2.5 millimeter drill bit. Perfect positioning there for your Mackay hole. You can see the distance from the cranial tip. And this is utilizing that thickest peg distally to help pull that osteotomy channel a little bit more cranial compared to if you were to use the smaller one, and then you'll end up too far down the shaft of the tibia. Really important when you have that drill sleeve in to keep some pressure on it, because as you start to oscillate with your saw, it can start to slide up, and you can lose a little bit of tension in that rigidity of the saw guide. So just keep a little finger on that as you go. Irrigation, really important. You're working in a much smaller channel, thinner bone, so you pop through to the lateral side much faster. You know that your patella tendon is protected by the proximal peg, so you can cut through proximally, distally, and so you can see the osteotomy goes a lot quicker in this thinner, smaller bone. Once you remove your Mackay drill bit, it's just a matter of completing the osteotomy, and this is when it becomes really, really critical that you have control of that saw blade and the power behind it, making sure that you don't create too many additional planes of cutting. And I will tell you that sometimes the osteotomy is complete already by the time you take the saw guide off. For some reasons, especially if you end up a little bit too cranial, you may have actually completed your osteotomy. But if you still have that little narrow isthmus, you complete it in the manner that we discussed. So determining your size of the implant is based on that chart. We're still going to advance, starting with one of the lowest, closest to the size of implant that you're planning to put in. No soft tissue dragged in. Making sure that your trial wedge sits flush with the surface at a minimum or slightly proud. Then switch that out for your appropriate wedge implant. Assess that the distal end, or the more importantly, the proximal end, is where you'd like it to be based on your radiographic planning. Flex the stifle, and then now it's a matter of establishing that pre-compression, as we talked about. Almost never use the K-wire with these little guys, but for this particular, I'm sorry, I won't use the K-wire if I'm using a staple oftentimes, but if I'm planning to do a tension band and wire, then the K-wire is absolutely necessary. So you can see the two holes, the butterfly guide only goes in one direction so that you can place your K-wire properly aligned. You do a pre-measure for the length to make sure you don't punch through too far caudally, and insert full throttle. And it's nice to have an assistant do some irrigation. You just pop through that caudal cortex, as you can see there. And then the K-wire, having been inserted now, has essentially locked that implant in place to prevent it from migrating proximally or distally. And now we can complete our fixation distally. So because we're going to do a tension band demonstrated in this video, we'd like to go ahead and bend that K-wire, cut it and bend it. And I usually, for the standard and medium breeds, I usually don't bend and cut until after all the fixation's attached, but you'll see the reason why we have to have it attached there now and cut in order to keep our tension band wire in place and stable without sliding down. So expose your Mackay hole, and you'd like to be at least a centimeter or so distal to the Mackay hole for your transverse distal wire hole. I usually start off somewhere caudal to that cortex, so about 6 or 7 millimeters if you can on that small bone, maybe 3 to 4 on this little guy, starting perpendicular and then leaning, angling your your drill bit so that you're coming out just slightly cranial on the lateral side so that you can avoid the cranial tibialis muscle getting wound up in your drill bit. And you pass your distal wire, which is a nice long length of wire to work with, bend it and form it into a figure of 8. And that's going to serve as your twist. You'd like that twist to come up about the level of the Mackay hole where that figure of 8 forms. And then we'll anchor the proximal wire around this. I often use a single wire for these, so I use a long length of wire after I form the figure of 8 twist. I'll just loop one end around, usually the medial side or the caudal one, looped around and then twisted laterally. So I use a single wire that I twist, and then you can tuck your twist into the cranial tibialis fossa adjacent to that cranial tibialis muscle thereafter, so it's not bulky on the medial side. So a single wire works just as well, even though I know that the double wire technique, the double twist technique, has been tested as much more, much stronger and stiffer repair. It generates much more tension and compression. So, but the single wire works really well, especially for these little guys as well. And there's less of a going back and forth, since you have to alternate your twisting back and forth to get it uniformly snug. And it's nice to have your assistant give you a little bit of leverage on that leg in order to get appropriate twisting and bending as you go along. And, all right, so that's essentially it. Once you've done this, twisted evenly on both sides, the last thing I like to do is to remove my clamps after I've cut and twisted and bent these down. And I'll take my finger and try to push on the proximal end and distal end of my implant to make sure that it's stable and not moving at all. If I still have some instability, then I might tighten my twist just a little bit more for some reason. But it should be really, really snug, good friction there. And then more importantly, you want to have abolished your cranial tibial thrust in so doing. All right, so that's the small breed fixation. You can see from these, there's multiple different ways to stabilize the distal fixation on these. We have now introduced a mini staple, different from the small staple. You can see the difference in length, which gives us a little bit more versatility to work with. And there are multiple different ways to secure with a tension band and wire fixation, either around the K-wire or through a separate drill hole as well. So many different ways to do it. And you can see how the implants go in either with the Mackay hole drilled, without the Mackay hole drilled. In this particular patient here, this one here as well, you can see this was a freehand osteotomy, which we'll talk about here shortly. So in very, very small dogs, that saw guide is really, really oversized. You just run out of room working with that thing, and it's way too long essentially for the length of the osteotomy that you're dealing with. We know we've got 20 millimeters to work with as far as length, and so you can freehand perform your osteotomy. And what I would recommend you do is make your measurements as you would on your radiographs. Use your K-wires to figure out those 2 spots, or use cautery to mark them, and then mark your proposed osteotomy with your cautery pen or some other form of marking. And then you can freehand use the oscillating saw, making sure that you're perpendicular to your surface and your assistant is holding the leg and the bone flat onto the surface. It's a little more daunting to do the freehand osteotomy, but if you do any cranial closing wedge osteotomies or ostectomies, you have some skill with respect to doing that femoral head and neck excisions. So you've used that saw blade. So it wouldn't be the first set of surgeries that I would recommend. I wouldn't, if you haven't done many of these small dogs, I wouldn't recommend your very first one to be a freehand sawing, but it is possible. So that begs the question, do we put a K-wire in or not? It really isn't necessary, to be honest. It does add a little bit of stability, as I said, to prevent proximal or distal migration of the implant, mostly proximal. And the goal is that if it's going to add some additional stability or an anchor point for additional implants later on, it's nice to have it in place, but it's not absolutely necessary at all. In every early case that you do, I do recommend it, just because it is a nice landmark to utilize to not only add some stability, but also to help with planning of your distal fixation. So if that tibial tuberosity is unstable, this adds just that little bit extra, but I wouldn't count on just that to give you your stability. Obviously, you still need to establish pre-compression across your wedge bone interfaces, but having it in place does give you the option to allow your tension band to go around that wire. So determining which one you use is based on the size of the dog, the size of the bone that you're dealing with. How much bone stock do you have available? In very, very thin tibial tuberosities, you may not have a lot of bone to work with in order to put a staple dead center in that tibial tuberosity. And that example that I showed before was 4 millimeters of thickness of bone that we're working with distally. So somewhere in the middle of that would only be 2 millimeters from the osteotomy, and that can be challenging. Your drill bits can sometimes skate off the cranial edge of the tibial tuberosities. And so these are patients that I would consider using a tension band and wire fixation for over a staple. But if you have some tiny breeds that have a very, very thick proximal tibia, very prominent tibial tuberosities, and we've seen those, you may end up with a lot more bone to work with as a result. So therefore, by all means, put in your staple, because the staples actually do provide you with a lot of flexibility, and they're much easier to place as well, I think, without the need for twisting and tucking and that sort of thing. So if you do your tension band and wire fixation, it's really important to do it properly. So small dogs and toy breeds, if your distal tuberosity is quite thin, and then for revision surgeries, when you do have loss of tibial tuberosity reduction distally against your wedge, doing a revision with tension band and wire fixation is clearly indicated. So there are many complications have been related to that poor wiring technique. So it's really important to pay attention to some specific details in order to get good, uniform, clean fixation without damaging your tissues. So my recommendation is to start with your osteotomy, as I said, about 10 millimeters if you're working with that, if you have that kind of length on the bone for that particular patient, 10 millimeters distal to your Mackay hole, and about 7 millimeters caudal to your cranial cortex. In the smaller dogs, you may need to cut that down to just whatever the radiographic thickness of your cortex is for that distal location. And then that allows you to drill your holes starting perpendicularly, and then, as I said, leaning and your drill bit slightly and drilling in a little bit more of a diagonal or oblique angle in order to avoid your soft tissues. Right. And then proximally you twist, and this shows a single wire twisted instead of having bilateral twist in the wire here. But if you do elect to do not around your K-wire, you can also do another separate hole in the tibial tuberosity itself, distal to your K-wire. And that I would recommend starting somewhere about 50% of the thickness of the distance between your K-wire and your MAC-K hole. And as I said, dead center in that tibial tuberosity from the cranial edge. It's really hard sometimes to measure the distance from the cranial edge, so I make all my measurements from the osteotomy itself to give you some idea, and based on the information you have from your radiographs, how thick a tibial tuberosity you ended up with. But I'll measure from the osteotomy gap or the bone wedge interface rather than from the cranial to tibial tuberosity, because that thick periosteum can sometimes make it a lot more challenging to figure out how much bone you're working with. Right, and this is what the two techniques look like. Both of them very acceptable, appropriately placed. Really important to get that pre-compression using flexion of the stifle as well as application of your point of reduction forceps. So I'll show a little video that goes along with that and gives you some idea as to what the technique looks like, appropriately looking at those soft tissues. So making that measurement, as I said, from the wedge bone interface rather than from the cranial aspect. You want to start off perpendicular and then slightly lean forward. This is with the first drill hole. Somewhere in the center of that distance between your MAC-K hole and K-wire. Angled, avoiding soft tissue. If you can. And then your distal hole, as I said, well away from your MAC-K hole and cranial cortex. And sometimes these wires, they're pretty stout, and these small dogs can actually cut through the bone. So you need to be very, very careful when you use this technique, that as you're tightening, you're not fracturing your tibial tuberosity. Same principle, angle to avoid soft tissue. So those are your two holes in this technique, utilizing two wires. To affect your tension band. Yep. So twist for the figure of 8, so it forms right over your MAC-K hole, and then twist the two ends of your wires together, evenly twisting to secure. And what's not shown here is pre-compression with a clamp. And your point of reduction forceps can be placed from the point of your tibial tuberosity just above your K-wire and across the back of the tibia to get some pre-compression before you put this in place, so that you're not utilizing the tension band to create the compression that you want. You're just securing the pre-compression that you have already, because I've found that as you twist, sometimes you end up, as I said, cutting through the bone needlessly, trying to get the compression rather than just maintaining what you've already established. So very good technique. Stabilizing, and then I palpate my wedge, make sure it's stable, and then cut and bend your K-wire thereafter. Stable compressions, it's a stiff titanium implant. It's stronger than the twisted wires, which based on Simon Rowe's work has shown that twisting, most of those wires failed at the twists or just beneath them, with the stress concentration being highest there, whereas the staple maintains its shape and stiffness throughout, as long as you get established pre-compression, right? So you want to have no space in between your wedge bone interfaces, cranially or caudally, before you put your implant in place. And I put a clamp distally across right at the level of the Mackay hole, if you can get good thick bone there, across to the back, and then another one from the point of the tibia to the back of the tibia. That gives you a lot more working surface to work with. Planning to put your K-wire, I'm sorry, your staple somewhere in that distal 1/3, or more simply 50% of that distance between your K-wire and your K-wire hole and your Mackay hole. Always, 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 always use a staple drill guide. It is predetermined for the standard as well as the small distances and lengths, and also now for the mini staple guide, we have that available for the smaller staple. The drill sizes are smaller, obviously for the mini, but for the small breed and standard, it's 2 millimeters to accommodate the legs that go in. Each of them comes with their own inserter that can be used to hold that implant more perpendicularly planed as it goes in, and a good thick striking area with our inserter as well, the drill guide. Here are the dimensions for those implants, and that helps you determine the size to be used based on how much tibia you're working with, right? So the tibial tuberosity morphology as well as the back of the tibia. You don't want to be placing standard length size 7 spanning all the way across the bone and not avoiding the appropriate locations on the bone. So let's talk about how we place these and what lengths are suitable and what are the no-go areas. So this chart shows 3 different sizes of systems and implants that you choose to use, and what sort of planning you can do with respect to the staples or tension band that you like to put in. You can see here in red that as you go up to the giant breeds or the larger size patients, I start to think about double stapling when I hit a 12 or bigger in certain breeds. And my cutoff that I'll share with you later is any patient that's above 37 kilos, I almost routinely put a double staple in, even if they're not a giant breed. Fat dogs sometimes will exert tremendous amount of force on your implant, and a single staple may not be sufficient. So just a rule that I added. It's not hard and fast, but it's been safe for me over the years. So staple placement, stifle flexion is really important to provide a little bit of initial compression across the soft tissues. Apply that those point of reduction forceps, as I said, sometimes proximal, sometimes distal as well. And the rule of thirds apply. So cranial 1/3 as well as distal 1/3 is a good working spot to place your initial cranial hole. But now I just plan to go 50% of the distance between your K-wire and your Mackay hole for your first for your first staple hole, dead center in the bone. Start off just by marking the bone monocortically, and then switch to your drill guide and complete your drilling using the drill guide so that you hold it flat up against the bone, go bicortically with your cranial drill hole for the staple leg, insert the peg that holds the drill guide in place and allows you to go 90 degrees to the staple, to the long axis of the tibia, or 45-degree angle if you choose to. I think the 90-degree angle is a lot easier to do rather than the 45, and it avoids the places, the caudal drill hole is monocortical. Leave a small K-wire in that caudal hole as you lift the drill guide away so you can find the hole, and then insert your staple perpendicular to that long axis or that medial tibial surface as well. Assess your implant thereafter. All right. The default size and position of that staple is always going to be a small staple placed at 90 degrees to the tibial long axis. And that can be placed, as I said, 50% of the distance between your staple between your Mackay hole and your K-wire, or in the distal 1/3. Very simple to do. So you can either divide this into 50% or thirds and determine where exactly the staple placement is going to be. If I'm placing 2 staples, I usually place my distal one first and then place the second one proximal to that. But it all depends on the particular patient as to how much bone I'm working with. Making sure that your drill pilot holes are in good bone stock. Cranially, it's bicortical, caudally, monocortically, and avoid the cranial and caudal surfaces, the cortices, your osteotomy edge, your wedge itself, and your Mackay hole. You want to be ideally 3 millimeters away from any of those surfaces. So based on the thickness of the periosteum, as I mentioned, it's really hard to determine how much bone you're working with. So I make all my measurements from the osteotomy wedge bone interface to ensure that I'm sitting on bone and not soft periosteum, all right? So with that, you have this whole distance to place your staples distal to your K-wire. Similarly, the caudal cortex, there's popliteal muscle that's covering there, the pes anserinus, and those, I take a needle and walk off the edge, find the edge of my cortex, and then go 3 millimeters from there, determined to not use too large a staple if I don't have to, but if I need to use a large staple, especially proximally in the bigger dogs, then I ensure that I'm avoiding that caudal cortex. Excuse me. Here's a nice staple placement guide chart that goes through from the mini staple all the way up to double stapling. And pay attention to this one with the red mark here. We want to avoid the areas around that Mackay hole to avoid creating stress risers and potential risk for fracturing your tibial diaphysis. So avoid that reddened area. Now, we actually have increased that area to show you want to avoid the cranial cortex as well as the caudal cortex. So this shows you very nicely what sort of free areas you have to place your staples, either 1 or 2 staples in that area, in that region above the Mackay hole, avoiding these cranial and caudal cortices. So here's what a small breed staple looks like in a tiny dog versus a mini staple. And you can see that the mini, with its smaller size, really adds a lot more versatility to placing that staple and obviating the need for tension band and wire fixation. These are some examples of what poor staple placement looks like. So we've got several things to look at here. On this image on the left, clearly this staple is way too proximal, too close to your K-wire. The K-wire is inserted very nicely just in the caudal cortex, but the proximity of this staple, this surgeon didn't pay attention to this distance between here. It looks like they tried to drill at the 50% mark, but somehow skated off the back of the bone because they didn't pay attention to the size of the staple that they were using and used the staple that was too large for this patient. So I would have gone down to a small staple, as I said, as the default, rather than the standard staple, and you would have been sitting in nice, good quality bone at the 50% mark above the Mackay hole and distal to your K-wire. So too close doesn't give you the compression that you need that fights the proximal pull of this quadriceps mechanism. This particular patient, the cranial leg is too cranial, the caudal leg is too caudal, and so you're not sitting in good quality bone stock, even though the positioning is just above the Mackay hole. It's not ideal either, but it's within that distal 1/3. But this has a potential for failing. And you can see that this surgeon also got a second plane of osteotomy here adjacent to their initial osteotomy, probably when they were trying to go through their distal isthmus. Similarly here, this K-wire is adequately placed slightly past the caudal cortex, but the proximity of this staple, which is in great plane, right? You can see superimposition of the legs right across that horizontal body of the staple, so that it's in a good perpendicular plane, however, way too close to the staple to provide what we need. It's sitting in good bone stock, but if it had been placed 50% of this distance or in the distal 1/3, around 66%, would have been perfectly ideal. That said, there is a possibility that of these three, this particular patient here could potentially go on and have no issues because of really decent pre-compression that was established. There's only a very thin linear opacity, lucency just adjacent here distally, but not terrible. So this patient might go on to have no problems at all. Whereas for these two patients, I would be very worried about these staples loosening because of their proximities to the cranial and caudal cortices. The giant breed dogs, I do recommend omitting that distal peg to prevent you from creating too diagonal a cut, because that distal peg will shift your saw guide positioning that makes you angle way too far out. This is a great patient. This is actually the reason why I came up with that idea of using the K-wire for measurements, because I want to make sure that I can get the angle of the osteotomy parallel to the cranial cortex much better, and determine where my K-hole was going to go, omitting that distal peg in the saw guide. So really important, and obviously, as I said, for these patients, always do a double staple in these patients. I still prefer the 90-degree placement of K-wires versus the 45-degree angle. My reason is that you can see where this most proximal staple hole is very close to the Mackay hole, which I think has potential risk for getting some stressors across here and propagating fractures through the tibial diaphysis. So I'm not a huge fan of the 45-degree angle, so I've been teaching now to do like these, the 90-degree angles. So here's the very first patient that I did that K-wire technique, and you can see a really thick bone, the location of the Mackay hole, and the position of the two staples, splitting the distance perfectly 1/3 all the way through for those two staples. The double stapling, I think, is worthwhile in all patients, all giant breeds, and any patient above 37 kilos. I think that these patients will generally do well. Here are two patients that had no K-wires placed, and the staples are actually placed at the level of the K-wire. It does add some stability for compression, more proximal across there. It's not something that I would routinely recommend doing, but it can be done that way. I usually still place, most of the times, the separation that we see is distal to that K-wire hole. So any compression I do with staples is usually distal to that K-wire hole. Mechanically speaking, that's the place that you want it to be. So follow-up radiographs, we do immediate post-op films, cranial, caudal-cranial, as well as medial-lateral, and then follow at either 4 or 6 weeks. And then if your patients will come back at 6 months, that's even a plus, cherry on top to figure out how much healing has taken place. And this is a really, really nice case that demonstrates perfect stability of your implants, both the staple as well as your wedge, remodeled healing, smooth contour to the Mackay hole as well as your distal tibia, and good bony end growth as evidenced by no osteolucency along your wedge bone interfaces at 6 months. Fantastic. And so this gives us a really nice picture to show that even without the K-wire in a fairly sized dog with a standard breed MMP, that a single staple technique in this dog went on to heal perfectly with no thickening of your patella tendon, no progression of osteoarthritis, well, minimal, I should say. I would say no is a stretch, but minimal progression of osteoarthritis from your immediate post-op to 6 months out. So let's look at critical radiograph review. Really important. I still review all of my images that I take, all of my surgeries as critically as possible, because I always can stand to learn something new from what I'm doing. So my recommendation is to be critical on yourself, to try to improve every time. We can always learn something new. So medial lateral views as well as caudocranial, craniocaudal. And one of the first things I look at systematically is the position of my implant. Sometimes, as I said, we're forced to place the implant flush with the proximal aspect of the tibial plateau because we run out of room distally based on the length of the osteotomy for that particular patient. Absolutely no problem here at all, placing it flush proximally. You just don't want to overdrive it distally into the Mackay hole. That's my recommendation. So avoid the Mackay hole if you can, in addition to utilizing no more proximal than flush. These two are showing that the implant was placed distal to that tibial tuberosity surface, or the tibial plateau surface, sorry, and ideally somewhere between 1 to 2 millimeters below that surface is ideal. This one's a little bit further, but still above your Mackay hole, so I'm okay with that as well. With respect to the Mackay hole, I like to see in a true medial-lateral radiograph where the condyles are superimposed here, that you actually have a perfectly shaped Mackay hole. It's a true circle, right? There's a little bit of obliquity on this, a little bit of obliquity on this, and you can see that you still have a circular hole. And what that says is that where you've drilled your Mackay hole and as a result, position of your osteotomy is in a true medial lateral plane. You went perpendicular to that medial surface, and that's important to see. If you see an oval shape or worse, an elliptical shape, then that suggests that there's been some angular cut, which could change how your implant sits against the bone. And there is a greater risk of implant failure as a result of that. So I do take a look at that in addition to looking where that distal end of your implant is sitting with respect to the Mackay hole. Next, I look at the implant that was used for stabilization distally. In this case, the 2 staples. You can see that with respect to the plane of insertion, we'd like to see the 2 legs superimposed across that body of that staple, which tells me that radiographically, again, in a true medial lateral film superimposition of the condyles, you have got a staple that went in exactly perpendicular to that medial surface. Compared to this, where you can see the legs individually tipped away from, this implant may not have gone in. There is some obliquity here, but this implant may not have gone in a perfect perpendicular position. And why that's important is that when it goes in perpendicularly, the legs insert and the interference fit in that pilot hole gets the most of the maximum benefit of the compression that's formed by that stepwise taper on those legs. When they go in at an angle, they're not mechanically as superior as if they were to go in perpendicular. Okay. With respect to the tension band and wire fixation, you want to see where your hole is drilled at least 1 centimeter distal behind that cranial cortex as well, anchored around properly, and more importantly, that you have good even twists on those. With respect to pre-compression, there's what we would like to see. We want to make sure that we don't see any lucency, if we can, between the bone and the wedge interfaces. So see how nice and tight this is proximally here. You can barely see any lucency all the way around on this particular patient in a true medial lateral film. This one is acceptable also, but just caudally here, you can see a thin area from about the K-wire distally. So looking at that, whereas there's a lot more lucency visible here on this patient, so not the best pre-compression. So that's even with having a double tension band on here, 2 wires twisted in addition to trying to establish good pre-compression. That's changed a lot over the years now too. All right. Being super critical about how much K-wire is exposed caudal to that cortex. It's really important that you don't advance too far because it's uncomfortable to the patient. There's no need to increase morbidity in them by having the trocar tip poking into the gastroc muscles. There's no need for that. So try to pre-measure beforehand to make sure. Some of these, I can show you some images later on, that K-wires that were placed far too caudally, and there was clearly no predetermined length that was placed in the drill chuck beforehand, which isn't, it shows sloppy technique, and I would try to recommend that you pay attention to each individual component of this surgery. And the K-wire placement is one of those critical steps as well. Lastly, on the caudocranial film, if you have a true caudocranial film, patella's dead center, fibulae are cut 50% of their thickness by the medial and lateral cortices of the femur, and your dead center on, we want to see that the lateral aspect of your wedge is not superimposed over your lateral cortex of the tibia. What that means is that if you have proximity or superimposition, your implant has actually been positioned too lateral, and rather than sitting flush or slightly proud of the medial cortex, which is desirable. Too lateral increases the likelihood that it's going to subside into exposed cancellous bone rather than be bridged and braced properly, buttressed by that. Here's a brief video to highlight what some of these patients look like very quickly after surgery, courtesy Dr. Ian McQueen. This image shows a very nice video of a dog right after, the day after surgery, large Newfoundland, walking right after the surgery, one day post-op. Not perfect, obviously weight bearing, but the fact that he's willing to weight bear is really impressing. And look at this, willing to stand on that operated limb to urinate. These patients, their morbidity is much less than certain other procedures where you do osteotomies on these tibia, where they're a lot more painful. Judicious use of analgesics definitely helps, but even for a dog of this size, remarkable that. And here's another patient, 10 weeks post-op, showing functional use of this limb, this shepherd. Just brilliant, the way they walk. You can see that there's a little bit of being very critical, gait abnormality, a little bit of a quick step on that right side for a left-sided surgery. But the functional use of the limb, the owners are quite pleased with this outcome. So with respect to outcomes, we look at not only limb function, is there lameness, and we can grade that accordingly. Is there visible or palpable osteoarthritis radiographically and with our exams? And then, have there been any major complications that required a second surgery? The most important aspect of all this is how satisfied are our clients with the procedure. And so there have been several studies along the way that actually looked at these outcomes. Return to function being measured by visual analog scale by owners, and you can see that there's high long-term success rates for all three of these procedures, tightrope versus TPLO versus TTA. And the TTA, by comparison to tightrope and TPLO, even though it fell short 1 year post-surgery to get back to 100%, still at 89 to 90%, the function is still considered appropriate, and most people were satisfied with their patients having had a TTA. This is not MMP, this is TTA. So highest levels in frequency and severity of pain was noticed in the TTAs, but that was not a significant finding. Restoration to full pre-disease status without the need for medications, the TTA also fell short with fewer than half of those patients compared to TPLO and tightrope. But surprisingly enough, surgeon experience level was not associated with complication rates, subsequent meniscal tears, especially for the TTA. So there are some specific learning curves that need to be matched and go through for each of these procedures clearly. But as we saw with that Newfoundland, with an MMP, 1-day post-op, functional use of the limb is very achievable. Ursula's group out of Cornell back in 2016 did a prospective long-term comparison of unilateral cruciate deficient stifles in dogs, comparing the 3 surgical procedures. It was a prospective for TTA, and they compared historical TPLO and extracapsular repairs to unaffected normal dogs. Low numbers of TTA, but utilizing force plate gait analysis, they managed to come up with hind limb symmetry indices looking at peak vertical force, vertical impact, and contact times. And looking at these dogs preoperatively at 2 and 8 weeks, and then also at 6 and 8 months post-op. And what they found was in the initial stages, the first 50 days, the TTA seemed to be outperforming the other 2 surgical procedures with respect to morbidity and limb function. And you can see that even though we're not up to a symmetry index of 1, which is considered normal, it's a bit higher than the other 2, and that was significant. As time went on, the TPLO continued to outperform at a walk, and the same thing happened at the trot. So sex, age, body weight, size of surgery, the type of tear, whether partial or complete, and whether or not there was a meniscectomy, didn't have any effect on the outcome parameters at both the walk and the trot. That was a significant finding for all of the procedures around. But at the walk, the TTA achieved achieved the symmetry index similar to controls after 300 days, almost at 1 year. There was no significant difference between the TPLO controls at 6 months, essentially, whereas the TTA group continued to be less lame than the other 2, as I said, within the first 50 days. Recently, there was a publication in VCOT this year that we were very excited to see, because it was the first side-by-side comparison of TPLO and MMP with equal numbers, not tremendously large numbers of cases, but certainly enough to give us some reasonable information that we can extrapolate from to some degree. And this was a prospective randomized control study that looked at these 2 procedures, evaluating the patients clinically and radiographically, and also on force plate ground reaction forces. So looking at outcomes at 6 weeks and 3 and 6 months. So not tremendously long period of time, but sort of midway to intermediate duration. So there was significant improvement in ground reaction forces in all surgically treated patients. So both groups functioned to improve from their injury state, got better. There was no significant difference between the surgical methods at any postoperative time that were re-examined. Nor age, body weight, meniscal lesion similarly had no influence on these results. And very interestingly, the preoperative OA score was the only covariant that influenced these results. And interesting to note that the dogs that were assigned to the TTA, the MMP group, had higher lameness scores than the other 2, just randomly. Okay. So here's a nice plot that looks at the results of the mean peak vertical force from both methods at different time points. And you can see that within the first 6 weeks, there's a tremendous increase and improvement in mean peak vertical force that levels out over time, with the TPLO performing slightly better than the MMP over time, especially once you get to 6 months. So, busy slide, but we'll highlight a few things. There was the largest clinical improvement as seen within that first 6 weeks. Compared to the control group, there was a significant difference at every reevaluation time point, with the MMP getting close to 90% of peak vertical force at 6 months, and TPLO outperforming at 94%, with that not being significant clinically. The only significant difference was at 3 months, where the TPLOs seemed to have a little bit better performance, as I said, about midway through compared to the MMPs. And at the end of 6 months, the TPLO did look better, use of the limb. With respect to complications and osteoarthritis, late meniscal lesions were the most commonly found major complication that required a second surgery, with 2 MMP patients requiring that and 3 TPLO patients. So low incidence of late meniscal injury. And with respect to all other complications that were considered catastrophic, all of those occurred, unfortunately, in the MMP patients, but it was one single patient that had all these problems, and that dog was allowed to exercise freely too soon. So there is a higher risk for complications, 3 times higher in MMP patients. So really important to follow the surgical protocols very, very carefully, and more importantly, to keep patients quiet after surgery, especially during that first 3 weeks. And I'm extrapolating based on information that we've gleaned since. But for this particular paper, postoperative meniscal injury was still the most common major complication, which has been reported elsewhere. 3 times higher risk of meniscal tears in TTA compared to TPLO. And the actual cause of that is unknown. Many of these patients are not undergoing routine evaluation of their menisci during surgery either. And that's something that continues till today, with no routine arthroscopy or arthrotomies being performed. So meniscal injuries still continue to plague us. It's the elephant in the room, and there's no true consensus, truthfully. A lot of it comes down to the surgeon's preference. I myself have gone from exploring every single joint and only treating the menisci that were problematic, to having gone through both the TPLO and the TTA training and MMP training subsequently, went to doing meniscal releases for every single patient, which didn't seem right. And then now I'm at a point where I only intervene surgically when I have a really strong suspicion that my meniscus could be damaged based on multiple different techniques. And I'll go over some of those with you. My biased opinion about what I do presently. It's somewhat scientific, but it's not perfect, obviously. And what's in the literature can be somewhat confusing, because you can find papers that support arthroscopy and or MRI or other forms of examining the meniscus, depending on who you read and who you trust, and then others that say it may not be absolutely necessary. So subsequent meniscal injuries versus late meniscal injuries really have to do with, did you look at the meniscus and miss it beforehand, in which case it's a latent tear, versus subsequent tears that occur as a result of potential instability that still exists. Neither the TTA nor the MMP nor the TPLO abolishes the tibiofemoral shear forces 100%. Maybe there's a case for overcorrecting your TPLO by over-rotating, or maybe over-advancing the TTA to try to eliminate that. But there's so many other forces that occur within the joint that we may not be entirely abolishing what we believe is there. And because of our taking down some soft tissues as well, there's a possibility that we could be introducing some mechanical dysfunction as a result of muscular dysfunction post-op in the early healing periods that could contribute to this continued instability in the joint. So that all said, we do know that concurrent meniscal injury can be as high as 83% in some papers, so anywhere between 30 to 80%, somewhere around 50 to 60% is what most people tell clients, that it's worthwhile assessing those patients to determine whether or not they have concurrent cruciate ligament and meniscal injury. And I treat those, as I said. For the other patients, latent meniscal injuries have been reported as low as 2% and maybe as high as 25 or so percent, depending on which papers you read. Most important thing is that if you do end up with either late or subsequent meniscal injury and you treat those surgically, you get resolution in almost 100% of those patients. So North Downs specialist was audited by Scott Rutherford, and he found in a case series of 142 patients, they had late meniscal injuries in about 8.4% of their patients. And they did the MMP without arthrotomy in 54 of those, and 9% of them developed a late meniscal injury. When the MMP was performed with arthrotomy comparison, they still had LMI that developed in 8%. So there was no significant difference between performing the arthrotomy and not performing the arthrotomy. And that isn't an argument to say that the arthrotomy is not necessary. That's not what we're saying. If you do an arthrotomy, it's not wrong. If you don't do an arthrotomy, it may or may not be clinically appropriate for that particular patient that may develop a subsequent injury and now has to undergo a second procedure. But if you inform your clients ahead of time, I think it's worthwhile to evaluate your patient and determine if an arthrotomy is needed. But I wouldn't blanketly say that arthrotomies are not necessary. That's not what we're saying at all. With respect to meniscal injury diagnosis, there's several ways to do it. In the human studies, physiotherapists have a method of evaluating using what's called McMurray's test. It's obviously the human knee mechanics are different from the dog, and extrapolating this entirely into the veterinary patients is challenging, but essentially passive range of motion, flexing the knee and extending the knee while you internally and externally rotate and palpate your medial and lateral aspects of the knee for meniscal clicking, crepitation, or pain. And obviously with an awake patient, it's ideal because you get that sort of feedback, whereas for the sleeping patient, you don't, and you'll have to rely on meniscal clicks and profound crepitation, especially medially. So it definitely is worth considering, and I actually have adopted this into my clinical practice. We know that when there is a meniscal click, there's a strong indicator that the meniscus is torn, especially something fairly dramatic, such as a huge bucket handle tear or a cranially displaced caudal pole. But the absence of that meniscal click doesn't mean there's a normal meniscus, obviously. So my recommendation is to do a combination of things. I usually examine my patients before anesthesia, get my hands on them while they're standing, and their knees through a range of motion. And then I also do the same thing while they're asleep, doing that McMurray's test on them. And I combine that with the results of that with imaging. So if I get crepitation, if I get clicking, if I get pain, then that heightens my suspicion that I need to go surgically and explore the joint. I combine that with imaging to determine the need to go in surgically. And one of the things that we look at on imaging, you don't see tremendous amounts of there's no way to determine a meniscal injury, but one of the things that I use is looking at the thickness of that medial buttress, as it's called, or the periarticular fibrosis. And also, this is not a weight-bearing film, I recognize, but on some of these patients, I do get a suspicion that there is collapse of that medial joint space where the condyles are a little bit closer to each other. And then if I see that there's a profound enthesiopathy along this proximal medial aspect of the tibial plateau, that also gives me some information that I can use, and you can see that here as well. And so if I put all that together and I have a heightened suspicion that the meniscus is damaged, I will almost always explore those joints concurrently. And I perform either a mini arthrotomy, which is a mini parapatellar arthrotomy, or a caudal-medial arthrotomy, depending on the patient and what I feel like doing at the time. Other ways to diagnose: MRI has a 90% sensitivity and about a 97% specificity. CT arthrograms can be used, but this advanced imaging is not available everywhere. And so it's a lot more challenging to make recommendations for that. Most people have access to an ultrasound, and if you can get an ultrasonographer that has good experience with this to show meniscal pathology, then that's even better. So I think clients would appreciate that. I certainly would appreciate knowing that as well. And so that's something that I'm going to try to work with my ultrasonographer to get a little bit better. It just adds another piece of information to my bag of information to utilize to determine, do I need to go in surgically? Obviously, visualization with arthrotomy, arthroscopy, and probing is still considered gold standard at this stage. So how do we see this joint to access the meniscus? Getting exposure using distractors is really important. The GLPs are useful, but these stifle distractors really do help to spread the joint open, lifting the femur away from the tibial surfaces to get good access to and visualization. For manipulating the meniscus itself, utilizing a blunt probe to look at not only the femoral surface, but the tibial surface, sometimes sliding under the meniscus along its short axis, the curvature, less curvature, looking into the meat of that body will get a visualization of a panel tear, which wasn't initially visible. And so it's worthwhile doing a good blunt probing on there. And if you determine that you have to remove it or trim it, then using toothed mosquito forceps, Halstead type, or small Coker clamp, or a true meniscal clamp is usually very helpful. A really nice study was done by Antonio Pozzi's group out of Florida, and working with Arthrex. They showed that arthroscopy is superior from numerous reasons. Not only the exposure, the ability to magnify, as well as to have a light source on there, give you direct probing under magnification of both femoral and tibial surfaces, and the distraction that you gain by using their distractor is really impressive as well. So definitely direct visualization is really super important to evaluate these menisci appropriately. With respect to meniscal release, at one point it was advocated for both TPLO and TTA to reduce the incidence of late meniscal injuries. That has since been shown to destroy the functional integrity of the meniscus, so it's not something that is recommended for every single case anymore. Surprisingly enough, the papers will show that when they did perform meniscal releases, there were no more cases of late meniscal injuries. But the truth is, no one actually followed up clinically to see what was going on inside the joint. We just knew that they didn't come back for subsequent meniscal damage thereafter. So it has been effective, shown in a few cases, but it's also shown to have no protective value in others, looking at TPLO. So it's hard to advocate when you have both pro and con for the same condition. It's hard to advocate one way over another. Resecting the meniscus when there's a true large bucket handle tear and folding forward of that caudal horn, I think that there's some morbidity associated with that, and these patients actually can benefit from having the meniscus trimmed or removed if it's loose. And I do a subtotal meniscectomy, trying to spare that outer greater curvature where the blood supply and the hoop strains are abolished the best. Try to preserve some functional integrity of that if possible. So I do think that there's some benefit to that. But if you're unsure, just by exploring that meniscus, that integrity, maybe it's a bit sloppy or moving, if you're unsure, just leave it in place. And I just explain to my clients that if there's subsequent damage, we may have to go back in. And most of them are very, very comfortable with that. The goals of treatment for the meniscus are remove the damaged tissue where you can, insofar as preserving the functional attachments and blood supply as well. And you can trim the damaged bits using a punch or a shaver or a knife to resect what you need. You can resect the damaged bits, the folded components, you can resect that, or you can just do a meniscal release. And then some researchers are advocating repairing these under arthroscopy. So a quick algorithm by Antonio's group shows that if you have true pathology, you go through your different degrees of pathology to decide if you're going to resect, release, or repair. If there's no meniscal pathology, document and leave it intact. And then later on, if you need to go back into address it surgically, you will. But the release, I would say I do release some when they are loose, especially on their caudal attachments. I will release them and see what happens after I do the release. Does it fall to the back of the joint? Again, it's not scientifically proven to improve outcome, but on those patients that I've done that, I have not had to come back in surgically to do anything with them. Some patients, when you release them, you will hear clicking, but as long as there's no lameness associated with that clicking, I don't intervene. I tell clients that yes, it sounds a bit uncomfortable to deal with. It doesn't seem to bother the dog, and generally around 10 to 12 weeks after that, they spontaneously resolve. So technical errors and complications with this MMP procedure, they are numerous. I have been reviewing radiographs from different practitioners, sending them in, thankfully, to get some feedback to help them go forward. And many people are making some of the same technical errors that we decided to make some of those changes, as I said, with that K-wire technique to determine the osteotomy thickness of that tibial tuberosity position as well as thickness. So that's a clear one. So pull wedge positioning as well as osteotomy positioning, a huge one, something that we see repeated fairly frequently. And then loss of reduction of the distal tuberosity, we've seen wedge subsidence, we've seen, and then in disastrous cases, we'll have broken wedges and tibial fractures. Already covered late meniscal injuries. Thankfully, we haven't seen very many infections, but I will go over that as well. So poor wedge size and positioning, either the wrong size implant or wrong system was chosen for the size of the bone that we're dealing with. And that's exhibited here, where you have too long a wedge for the size of the tibial tuberosity and osteotomy that was performed. This ends up with placing your long wedge into a small osteotomy slot, and too much of your proximal aspect of your wedge is exposed above the tibial plateau. This is clinically unacceptable and should not be done. You can see where the K-wire was placed way proximal in here as well on the tibia, and that should not be done. This is clinically unacceptable. This is a patient that I would get out of surgery, see my radiograph, go back in, remove all implants, and swap this standard wedge out with a medium wedge immediately and do the whole thing over again. All right, so unacceptable, and that's something that you have the ability to correct intraoperatively, and if you miss it intraoperatively in your post-op films, you have the ability to correct it shortly after that. This is another wedge that was chosen, probably an appropriate size for this patient. However, the osteotomy was angled too far out the cranial edge rather than being parallel to the surface, and so you have a wedge that's exiting distal to your osteotomy and the Mackay hole. In fact, the Mackay hole is sitting off here somewhere in the distance outside of the bone. This osteotomy was made in a small dog far too centrally, almost central caudally. You can see down the center of the weight-bearing axis of the tibia. And this particular patient had numerous things go wrong with this, this surgery technique. Very little adherence to strict technique at all. You can see the K-wire was advanced way too far. The bend is inappropriate. The length of the cut was inappropriate. The location of the tension band was inappropriate. They attempted to put a tension band at this hole, fractured the tibial tuberosity, so had to go up above the K-wire. So I'm not pointing this out to belittle or to embarrass or shame anyone, but these are some of the things that we have control over. And I strongly recommend that if you're having issues with locating your osteotomy, immediately call to the patella, locating your saw guide appropriately to get the planned thickness of your tibial tuberosity and osteotomy, then utilize some of the techniques that we mentioned today to help you get to that point so that you can avoid making clinical technical errors such as these, which could be disastrous for the patient. Very important. Here's another patient that had an osteotomy that was too central, and the implant just subsided into the bone, and the K-wire was completely misplaced altogether. So there's just some technical errors that shouldn't be made, and upon recognition of having made them, there are ways to try to correct those that should be done immediately. Loss of compression, the reduction of the tibial tuberosity, very important as well. Something that we see very early on, usually within the first 3 to 4 weeks. And some of that comes from not establishing good precompression to begin with. And then the rest, the remainder of those has to do with poor maintenance of that precompression by inappropriately sized K-wires or tension band or location and positioning of your staples. So if you don't get good precompression beforehand along the wedge bone interface, or you don't put in your staples in appropriate locations or adequate bone stock, or securely in the bone, then you're going to end up with a higher risk of that loss of reduction. Some of them will progress only to a point and then don't go any further. And so this particular patient here, you can see that there's been loss both on the cranial aspect of the wedge and the caudal aspect of the wedge, with caudal subsidence of the wedge into the proximal tibia. You can see that angle change there. And this particular patient with soft tissue swelling, it's possible that this may never progress any further, but the reason why this happened is the position and location of this staple. The cranial hole is too close to the osteotomy. The caudal hole is sitting in good bone, but it's way too proximal. To prevent this from occurring, this staple should be all the way down here, a little bit closer to this Mackay hole, really prevent the proximal pull of that tibial tuberosity, of the quadriceps. So this particular patient, should we revise or not? Not quite sure. It's possible that this may get no worse, and I would follow these radiographically weekly to see what's happening. You may end up sweating a little bit with that. Whereas this patient over here has no stability of its implant whatsoever on the right. And this animal definitely needs to have a revision. Here's an example of a dog that had a one site done with an MMP, and the post-operative radiograph I reviewed and looked completely perfect. I'm not quite sure why that was a problem subsequent, but the client revealed that the dog was not restricted at home, was allowed to run and jump off the furniture and run to the front door to do all sorts of activity that it ought not to have done. All the while, it had a cranial cruciate ligament rupture on the opposite leg that came in at 4 weeks for that surgery. And while we were there, we did the 4-week radiograph to see what happened with it. And we weren't expecting to see that the first side looked like this. Having seen this, we elected, since we were doing the MMP on the opposite leg at the same time, we elected to revise this with a tension band. This is 4 weeks post. We were able to apply a clamp, a point of reduction forceps along the distal aspect here, gradually, 1 click at a time, reducing this entire thing. Not perfect reduction. You can see the pre-compression perfect, but placing the tension band, albeit a thin wire in this patient at that particular hospital that I visited that day, they didn't have anything thicker than that. What we had, I made sure to do a double wire, the most out of the tension band. But you can see that over time, there was subsidence of the implant into the caudal portion of that bone proximally. And but the revision looks clinically acceptable. So the options are there, which we've gone over, different combinations. Then ultimately, if you're worried, you can put a bone plate, either an SOP or forkless TTA plates are useful as well. When in doubt, increase your stability of your constructs before you get out of the operating theater, or after you've seen your post-op films. If you think you need some more stabilization, pop back in briefly and augment your repair. It's better to do a stitch in time than to have to deal with complications later on. Tibial diaphyseal fractures, owner compliance, we know, is a major component to the incidence of these within the 3 to 4 weeks after surgery. And most of the time, if you press clients, they will let you know that the dogs have been poorly confined. But when you combine poor owner compliance with technical errors, you're asking for trouble, right? And so some of these patients with very poor technique, you can see that abnormal or inappropriately positioned osteotomy centrally right down the weight-bearing axis of the tibia, in addition to poor placement of staples, leads to problems with a fracture that propagates all the way through and up and around the caudal cortex. Right? So technical problems, in addition to poor compliance, super problematic. So the good news is that it's low incidence because most of the time we can avoid these things from occurring. But when we add technical errors to it, as I said, distal staple, it's nice to put 2 staples in, but if you put your distal staple too close to your Mackay hole, you create this propagation of stress rising all the way through that allows these fractures to occur, especially in that first 21 days to 28 days post-operatively. This was shown, Malcolm Ness reported this in an AHA paper that looked at these dogs in the early stages of developing these fractures, usually as a result of placement of these staples or distal fixation. When you drill holes too close to the Mackay hole, these patients squat to urinate or defecate, and on rising, they create quite a bit of torque, a rotational torque in that tibia that leads to the propagation of these fractures. Oftentimes, the field will stay intact, and these fractures are usually minimally displaced. They tend to heal without full intervention as long as you can truly restrict their activity thereafter. So not everyone requires that. But placement of that osteotomy right in the center of the long axis of the bone leads to problems almost always. Poor placement of that staple, as I mentioned as well. So if you do have fractures of diaphysis, you can certainly plan to stabilize them if for some reason the clients refuse to restrict the patient's activities, or the dog is really, really challenging to deal with. You can put in a single plate that spans the distance caudal to your implant, to your wedge. That's usually a good location. And sometimes these patients require a second plate that goes up the tibial tuberosity, especially if the tibial tube is fractured. And I would recommend, as I said, spanning tuberosity all the way up to get the majority of the thickest bone. I would get this plate up and around the proximal curve. You can just avoid the insertion of the Sharpie's fibers of that patella tendon on the tibial tuberosity by rotating the proximal hole just slightly off center to get the most purchase in that. But these patients will ultimately heal very, very quickly, just buttressing these fractures. So risk factors we talked about for diaphyseal fractures. The risk factors for tibial tuberosity fractures are making your cut inappropriately cranially, so you end up with too thin a tuberosity to begin with, and trying to drill holes either too together or within that bone. You end up running right off the front of it, running through the bone, or you use tension band and wire. Sometimes you cut right through that thin bone. It's possible without adequate irrigation to have some problems with thermal necrosis as well in very small bones if you're trying to go through with your osteotomy or drilling. So really important to make sure that you pay attention to some of these technical specifics to get the best results. Tibial tuberosity fractures can be managed conservatively, some of them depending on the case. I usually recommend palpation of that tuberosity for instability. Sometimes there's, even though it looks radiographically horrible, it may actually be already attached and healing. When it's noticed, it may already be healing and attached proximally, and there may be no instability. If there's no pain, no instability, furthermore, no instability of the patella, either medial-laterally or proximally located patella alta as a result of these fractures, I may not intervene surgically to do anything on some of these patients. But when you need to, you can do a tension band and wire fixation to help pull that back into place and stabilize it when it's necessary. Sometimes you need to move some implants, such as this K-wire, which will get in the way of your other fixation techniques and methods. You can see this distal staple is loose. It was put in at a poor angle compared to this one. That one was more problematic. So you pull whichever ones, and because this one is in limbo, the front of this tibia, that's why that was removed as well. So broken wedges do occur, low incidence as well, mostly because of poor positioning of that osteotomy or poor positioning of the implant, not sitting it against the medial cortex, sitting too laterally, and as a result, you get some proximal subsidence. When you do get proximal subsidence of that proximal aspect into the soft cancellous bone, the pull of the quadriceps causes a stress riser effect around that central hole that a K-wire goes through, and that becomes the weakest part of the construct of the implant and causes it to break. Sometimes the tibial tuberosity fractures along with it, especially if you create stress risers by drilling right through the cranial cortex, such as in this patient here. So it's very important to pay attention to the technical details as to the tissues that you're working with, to eliminate some of these, because most of these complications that I've pointed out thus far are preventable for sure, known beforehand, and if you know what complications may arise beforehand, you can prevent them from occurring most of the time with appropriate technique. Surgical site infections do occur, especially if you have patients that have poor skin to begin with. or they're allowed to lick their wounds afterwards if you have poor tissue handling technique, etc., have tissues exposed for a long period of time, and or you have dried out your tissues without appropriate irrigation. All those contribute to it. That is well known. Rarely do we see surgical site infections associated with the MMP implants, but in Costa's study, which looked at TTAs, there's a fairly large study with 1,600 patients, and they had a 7% incidence that required only antimicrobial therapy to get resolution, which is really good. That was just irritation of the incision, either by sutures or otherwise, and there's some now medicated sutures that can be used, as well as different topical treatments that you can use on the skin in your surgical prep. Some people are using DuraPrep and Ioband to cover their skin and when we do surgeries. But most importantly is to evaluate the skin beforehand to make sure that you don't have any pustular or dermatitis beforehand. So deep infections, thankfully very low incidence in this paper, and what we see clinically as well. It's rare that these do occur, but when they do, we do have to do more in-depth debridement, irrigation, revision closures of the wounds, and long-term antibiotics. And when you have septic arthritis within the joint, then those take a lot more involvement. Some of them you do have to go in and actually flush and irrigate the joint out in addition to removing implants. There's no true association between the parameters and complications, but there was a tendency to see that older dogs greater than 8 years of age, they did approach significance in terms of predisposition to some major complications in this paper. The highest incidence was in a case report of 224 TTAs, where they had about 5% incidence, and that was directly related to prolonged surgery and anesthesia times, such that for every minute of increased surgical time and anesthesia time, there was an increased likelihood of surgical site infections, 7% and 4% respectively. And use of postoperative antibiotics did not prevent this from occurring. So antibiotics, we do know, are helpful, especially if you can remove the implants because of the risk of biofilms forming over these metallic implants, well noted with plates in particular. The design of the titanium orthofoam wedge with its small pore size should be very biocompatible to prevent infections and promote bony ingrowth, but any contaminated or infected wound can lead to infections that can get away from us no matter what we do. And so just having the design of the orthofoam wedge doesn't prevent an infection. And so some patients do require implants being removed. So in the TTA, implant removal was necessary in less than 2% of the cases in some early reports. With respect to MMP, when we do have septic arthritis plus sepsis deeply into the joint, into the bone, and we're getting worried about osteomyelitis, there are some cases where removing the implant is necessary. It's challenging, especially if there's been some bony ingrowth, but thankfully I've not had to do it myself, but I've read and spoken to other surgeons that have, and there is a chronic granulation tissue and fibrous tissue that grows at the wedge bone interface that may allow the wedge to come out without too much damage to the bone. Not easily, but still without too much damage. Sometimes you do have to use osteotomes or oscillating bone burrs or saws to cut along the sides of the implant to take it out. And then you maintain your tibial tuberosity advancement with buttress plating thereafter that goes through the implants. Certainly not something we would love to do, but when you have to do, you can. The idea of having to put more metal into a previously infected wound is daunting as well. So, and how do we reduce surgical site infection rates? Good theater practice, Obviously, as I talked about, making sure that you have good quality skin, aseptic technique, and any of these topical type therapies in the surgical prep that can be useful, Ioban plus DuraPrep, and good time of your antiseptics on the skin. Irrigate the tissues as well as handle the tissues without using too much cauterization, and making sure you don't do a lot of soft tissue dissection definitely helps. And then there's several other things. Perioperative antibiotics has been shown to reduce surgical site infections. There was a recent paper, I believe, early this year in VetSurg that recommended giving your perioperative cefazolin within 30 minutes to an hour of your incision, and every 90 to 120 minutes thereafter, for as long as the patient's tissues were exposed. Sending patients home on antibiotics for metallic bone plates is usually necessary as well. But I would say for MMP patients, I don't always send them home on antibiotics. If I have good technique, it's usually a fairly short procedure as well surgically. So generally not necessary to have long-term antibiotics thereafter. So there are a few theoretical advantages of MMP versus TPLO. TTA does preserve that natural tibiofemoral articulation because you don't move the tibial plateau. There are, as a result, natural load transmissions across the stifle and potentially protects the menisci. This is theoretical and not proven. So, but it sounds like there could be some advantage, although we do see clinically more incidents of subsequent meniscal injury than TPLO. So definitely the TTA does increase the extensor moment arm of the stifle so that it takes less of a work or force to extend that stifle compared to the TPLO, where we have a shorter moment arm and takes more force to extend the stifle, and that might contribute to either LMI or patella tendonitis. We do see thickening in the patella in some of these patients. So theoretically, there are some advantages of the TTA or the MMP technique to the TPLO, but that's left to be seen. Randy Boudreau had a really nice paper that compared TTA to TPLO back in 2009, and that looked at several different things. And one thing that I found very interesting in here was the anatomic configuration of the individual stifles. There are high insertion points of the patella and low insertion points of the patella. So here in A, this is a low insertion point of patella tendon, and B, high insertion point. And if you perform a TPLO on a patient with a high insertion point of the patella, after you rotate this proximal tibia caudally and distally, this loss of buttress between that thin portion of the proximal tibial, the patella insertion, that loss of buttress behind could predispose to fractures of the tibial tuberosity, which may or may not be clinically relevant. Similarly, if you were to perform a TTA on dogs that have a low insertion point, you can see that you end up with very short segment of bone in which to apply the implants. The newer plates, obviously, with the 2 screws on here, are a little bit more useful to work with, that prevents damage. These forkless implants are a little bit less worrisome, but there may be something to this configuration that's interesting. But that begs the question with respect to an MMP, which could solve the problem in both of these. And that wasn't looked at in Boudreau's paper, obviously in 2009. But just based on measurements alone, it's possible that the MMP may be superior to both of these procedures because of the less reliance on the insertion point of that patella tendon. Something of interest more than anything else, something yet to be studied. What about excessive tibial plateau angle? The TTA may not be appropriate for these because it's based on the premise of establishing a patellar tendon angle of less than or equal to 90 degrees. And it's possible that in some of these that the patellar tendon angle is already 90 degrees. And to really prevent cranial tibial thrust by tibiofemoral shear forces, you have to advance the tibia so much further beyond that to make that angle very small. And so it may not be appropriate. So for these patients, TPLO combined with CCWO or triple tibial osteotomies might be more useful. Very involved procedure, but these excessive TPAs are something that we see clinically worth taking a look at. So in summary, the MMP does offer a shorter surgery time. We saw that in the videos of both the small as well as the medium techniques. And you guys have had extensive experience working with these now, some of you, to show that by comparison to other tibial osteotomies, the MMP is a fairly short surgery. There is definitely a shorter convalescence, but I still warn clients that many of these patients will still be not back to their best or pre-surgery until at least a year out from surgery. And that's based on some of the reporting done by Ursula's group, et cetera. It's a simple, cost-effective surgery. It doesn't require a lot of extra kit by comparison to the TPLOs in particular, with outcomes that are, I would say, equivalent to TPLO, not superior to, but identical to, but fairly equivalent, with good functional improvement in some patients. We can treat very, very tiny dogs or small dogs all the way up to giant breeds. So there's a lot of versatility, and potentially the shape of the tibia may not influence the use of a particular procedure, just the size of the implant that you use, so the size of the system. It's extremely important to adhere to technical operating protocol principles, which we've seen. We've highlighted those things that have had some problems, and we know how to correct them, and we know how to prevent these things. So it's really important. Plan ahead of time, pay attention while you're in the operating theater to the anatomy that's sitting in front of you, so you don't make too many technical errors. That said, board certification and specialization is not required to do this procedure. And we've seen some very, very talented surgeons come through during my, my brief tenure of teaching these workshops. I've seen some very talented non-boarded surgeons work and do impeccable work. So I'm not here to disparage anyone who's not board certified or specialized in orthopedics. I'm a bit of a geek, so I spent some time working up an MMP surgery checklist. And this goes through step by step as a checklist for not only yourself, but mostly for your team that's in the operating room with you. They can follow along if you're training and teaching other colleagues to do the procedure, to assist or otherwise. They can follow along in the training that goes step by step so that they know, they can anticipate what the next step is be. And this is from before surgical incision all the way down to your post-op RAD assessment. And if you think that this might be useful for your clinic, I'm happy to provide a copy of this to Simon or Charles accordingly. Hopefully you guys are doing okay. We have just a few cases to discuss, and once we get through that, we'll open it up to general discussion with questions. So bear with me. A couple cases were submitted, and I appreciate those practitioners sending those in, those veterinary surgeons. So first one is Harper, a 6.5-year-old spayed female golden retriever, weighing just around 30 kilos. Presented initially in August with a chronic right hind lameness. A right MMP was performed in January, and the patient was examined at 4 weeks postoperatively and found to be walking well. Owner instructed to increase exercise. So here's the preoperative planning for this patient to determine how much advancement there was. Nice, pretty colors used, and the measurements look appropriate to me. I don't know what the actual ones were, but when you do measure appropriate, it seems that the initial work was done. The post-op review of the surgery, I think being very critical, here's a few things that I see. I think that the thickness of the tibial tuberosity is adequate for this patient, meaning that the location of the implant based on the thickness craniocaudally of the tibia itself gives us somewhere around 30% of that thickness for the tibial tuberosity. The orientation of the osteotomy is fairly close to parallel. It tapers slightly distally, but it's better to taper that way than it is to taper the other way going into the shaft of the tibia. And the location of the implant proximally is slightly a little bit more distal than I would love to have seen. You can see on the film that the Mackay hole is somewhat occluded or obstructed by the staple, but it almost looks like the distal end of your implant has gone down into the Mackay hole slightly, so maybe not as far distal, and then as a result, not as far proximal. The K-wire is just slightly advanced past the cranial, the caudal cortex by about 1 centimeter or so, paying some attention to try to pre-measure that length just up to the caudal cortex, which is palpable, or sometimes you can use a needle to determine where that's located, and don't overextend your K-wire. With respect to the pre-compression that was established, it looks like there's linear lucency that spans the entire length of the wedge in this postoperative film. And I think that it's difficult to know if this is the immediate post-op. I don't think it is. I think this is the 4-week radiograph, which showed that everything looks stable, but there is not such great compression here visible. I don't know if that was subsequent or something that was found immediate pre. The staple placement looks oriented appropriately in the 45-degree angle, sitting in good bone stock away from the Mackay hole, and also cranially within the center of the tibial tuberosity. If I had to be super critical, we have a really perfect medial-lateral radiograph with the condyle superimposed, and I can just see the staple leg slightly off perpendicular, so maybe not perfectly positioned. This patient surprisingly had a history of acutely becoming reluctant to walk after they were instructed at 4 weeks to increase the exercise, and then starting to turn the limb outwards, sitting awkwardly with some swelling and heat over the stifle at 6 to 7 weeks postoperatively. Sadly, this patient was lost to follow-up by the surgeon that performed the procedure, because the client, against the best recommendations, went to a physiotherapist who assessed the patient with pain and suffering and advised referral to a specialist surgeon. The specialist surgeon saw the patient, and at 10 weeks post-op, performed arthrocentesis, found no abnormalities, performed imaging and surgery, and thought that the MMP implants were stable, and that the alpha angle that had been achieved was fairly close to 90 degrees. The limb was stable, but there was some pain and swelling at the knee. They decided to do arthroscopy and found that the menisci were intact and stable, but surprisingly revised this by removing the staple and the K-wire, and performed a TPLO thereafter. I don't have the postoperative radiographs of the TPLO that was done, but I've heard of some people doing that, where you literally perform the osteotomy through the wedge. So you do the biradial osteotomy, cutting right through the wedge, rotate and put your plate in place along the caudal aspect, and expose the caudal bone on the tibia. It's unfortunate that we don't have good follow-up from the primary surgeon on this, but even with the specialist surgeon finding no abnormalities on arthrocentesis, no abnormalities on arthroscopy, but some pain at 10 weeks post-op, because we know that these patients sometimes can have a more protracted a course of recovery, I would say I would have waited a little bit longer on this patient to see what would have happened and utilize physiotherapy to our benefit rather than intervening with surgery. But I wasn't there. It's difficult to say. So this is frustrating, I would say, for this particular case, because there's a loss of communication, it seemed, and maybe some miscommunication by the physiotherapist. Apparently there was a suggestion by the physio that this was an outdated procedure that should no longer be done because it causes patellar tendonitis. And that has never been reported as far as I know as well. So I apologize that I don't have anything more on that, but it was an interesting case. And it would have been really nice to see the post-op TPLO just as a GWIZ sort of a thing, but I don't see a clear indication based on these radiographs as to why any more surgical intervention was required. The implants are not unstable. And as far as I can tell, everything was achieved with the procedure that should have been done. The second case is an 8-year-old American Staffy Border Collie cross that had an ongoing right hind lameness since May of 2019. It was examined under general anesthesia with radiographs of the right stifle in July, finding mild cranial jaw during flexion primarily, suspicion of a partial tear, and stifle pain on extension crepitation. Radiographs were otherwise unremarkable, suspected either a partial or complete cranial cruciate ligament rupture. Thoracotomy was performed in August and confirmed that suspicion, but the menisci were intact at the time. And an MMP was performed using a 9mm standard wedge. They were unable to pass the K-wire, and I apologize. Let me see if I can rectify this. Bring this to the front. Yeah. So this patient had a MMP done with a 9mm wedge, unable to pass the K-wire. They did several attempts even using a smaller K-wire, and I suspect that it must have had to do with the alignment of the butterfly guide. Maybe they were either using the inappropriate hole. I'm not quite sure. I can see the tract of that K-wire trying to get through the hole. The other possibility is that the wedge may have been loaded inappropriately in the introducer, and so the positioning was imperfect. It's difficult to say. I've not had that occur where it's impossible to pass that K-wire through. Even trying a small one didn't seem to make sense. But nevertheless, putting in a double staple, I mentioned before that some people have done this technique where they have placed the staple at the level of the K-wire or shortly thereafter. Most of the pull comes from distal, so my recommendation is to not staple this high. I would put a second staple distal if I were going to place a staple at all, because we do know that the K-wire is not necessary. It doesn't add that much mechanical stability. So that said, my recommendation on this is to, let's take a look at, let me, apologies again, for some reason this isn't lining up properly. Let me pop this to the back one more time. Okay. And so anyway, let me just give you my my feedback on here. I think that this implant was, the osteotomy was probably too caudal to begin with. Yeah. I think the osteotomy was too caudal to begin with. And as a result, we ended up with too thick a tibial tuberosity. And as a result, your potential risks for this patient increase as a result of putting that osteotomy in the center of the shaft of the feet, of the tibia. You did get parallel in your osteotomy, and with respect to placement of your implant, it looks properly positioned. I wouldn't have done anything different. The staples, the orientation isn't bad for a well-positioned medial-lateral film superimposition of the condyles. We do have a little bit of a skewing or tipping of those legs of the staples, so it's not perfectly perpendicular to the medial surface. With respect to pre-compression, not ideal. There's obviously some space there, so trying to get a little bit better positioning of your clamps beforehand will be helpful. And with respect to the craniocaudal view, this patient had probably a little bit lateralization of the implant as a result of I apologize again going through this. I don't know why it's come out of sequence, but what happened with this patient postoperatively is that at 4 weeks, 2 weeks post-op, rads were obtained because the dog was knocked over by its housemate when greeting a guest at the front door. So it was not well confined, obviously, as it was instructed to do so. And you see this propagation of a fracture that developed as a result of some shift and loss of distal compression, proximal shifting of that tibial tuberosity, and then propagation of this fracture across that caudal aspect of the tibial shaft, coming from that distal or that caudal staple hole of that distal staple. And that's clearly similar to what Malcolm Ness reported in his 2009 paper 2017 paper in JAHA that looked at that propagating fracture and when patients aren't, when they exhibit a lot of torsional stress on that bone. So not surprisingly, we see this here from a poorly positioned implant, poorly positioned osteotomy, unfortunately, and then you suffer this potential consequence. So interestingly enough, the fibula is still intact, which is nice, and that acts as, to some degree, a little bit of an internal strut to support this fracture and prevent it from displacing further, which is really good. And so this is a dog that I would have just followed up conservatively, which is what this surgeon elected to do. So repeated radiographs at 4 weeks post-op and found that the fracture had started to heal. The implants were otherwise stable, no further progression of any instability or loss of tibial compression against the wedge distally. And then at 8 weeks post-op, the fracture is essentially healed with a fairly robust callus and no further distraction distally. The implant's otherwise stable. The resultant tibial advancement is difficult to assess because of the location of that cut. But for now, the patient's actually utilizing the limb and doing quite well. So I would say that this is one that you got lucky with. There was no indication to go in surgically to do anything differently. Any changes that I would have recommended would have been at the beginning, making sure that your osteotomy was well positioned and that your K-wire did go through your central hole in the wedge and that your staples are properly placed to get the maximal mechanical benefit of their placement. So that's all I've got for you. I appreciate your attention. I appreciate the assistance of everyone in the Orthomed and Infinity Medical group. And as I said, I sincerely appreciate the opportunity to work with a great team of people in this group, and it's been a good time. So any questions, I'm happy to entertain those right now.
Brilliant. Well, thanks ever so much, Bruce. Yeah, we've had some really good questions come through. I'm going to start with a very easy one. Early on in the slide, you talked about a caliper measurements.
Yes.
What does that have an actual name?
Yeah, it's called a Castro Viejo caliper. Castro Viejo is a bit of a Spanish name, but yeah, they're, as I said, available. I buy mine from eBay, and I'm sure eBay is available on most of the places around. You can have a look, but they're fairly inexpensive, maybe between...
I think it's on Amazon, Bruce, as well.
Amazon as well? Okay. Yeah, so I get them for, you know, $6 to $10 at a time, and you can sterilize them in autoclave, and they work beautifully well.
Wonderful. That's great. Thank you. How and when do you make the decision whether or not to use a K-wire? Is that weight dependent, or is it an experience-based decision?
I think for every early case, I would say your first 20 to 30, I would recommend placing it, because I think it's an integral part of learning the system and getting comfortable. I would say routinely for medium cases, I almost never use it. For medium patients, for some reason, the length of the osteotomy is short or shorter, and there's no need for the fixation there. And because of the length of the osteotomy, not only of the length of the tibial tuberosity and the wedge distance between the K-wire and the Mackay hole, I don't see the need for it there from a mechanical perspective. So that's sort of what I use. So to some degree, yes, it is a clinical sort of feel, but honestly, it's using it is not wrong. It clearly is there for good reason. But if you don't place it properly, or you end up drilling multiple holes into the cranial aspect of the tibial tuberosity, and that would be less than ideal. So if you're going to place it, follow the technique recommendations appropriately.
Brilliant, thank you. And then there's been a few questions about staple placement and worries about if there's a lack of bone distally in the tuberosity. So if you're worried that you can't get a leg distally to the pin because not enough bone stock,
right,
what would you do in that situation? And is it okay to put it proximal to the K-wire?
There's no mechanical advantage to placing it proximal to the K-wire. So for those patients, I will just simply say no, staple, and go with a tension band and wire fixation.
Go with tension wire, fine. And actually on tension band wire, sorry, I'm doing these in no particular order, just
please,
that they come through. Sorry if it's jumping around a bit.
No.
For small dogs, what size tension band wire do you use? Now, the user guide says 1.2.
Yeah.
Sometimes on a smaller dog, using a 1 mil can still feel a bit thick. Would you go even bigger for a giant breed?
Yeah, for the giant breeds, I almost always use 2 wires to twist, and I use the largest possible. For the tiniest dogs, I agree, the 1.2 is quite thick and maybe a bit unwieldy, especially trying to hide the twisted portion of those tension bands is going to be really challenging. And thin dogs that have very little soft tissue to hide. So in the smaller dogs, I try to use a single wire rather than 2, if possible. And downsizing to 0.8 is reasonable, but it really depends on the size of the bone that I'm working with. Because my biggest fear on those is cutting through the bone with too large a wire. And
with the wiring, does it matter if the proximal wire is twisted over the distal and vice versa?
No, not necessarily.
No,
as long as it's secure.
Fantastic. Question that's come through. Some studies have suggested that fracture through the cranial cortex of the tibia from the Mackay hole, so I presume that means the bony bridge part, constitutes as a major complication when reported as a complication rate. Are you aware of this, and do you know what the thoughts might be for that?
I disagree. I think it's something that has been seen, and sometimes it occurs during the procedure as well. So I don't see it as a complication. I see it as an occurrence that has been reported. I don't see it as a major complication. Major complications to me are complications that require surgical intervention to go back in and correct. And so if I see this occur even at the 2-week or 4-week post-op film, I don't see a need to do anything about it. And I know people who send in radiographs always say, oh boy, you know, I felt horrible because I had a crack at this distal isthmus on that, but it seems to be mechanically a non-entity as long as you have good cranial, good compression, pre-compression and stability. It doesn't seem to be a problem at all.
Excuse me. Okay.
I would agree with that. And I just wanted to add with regards to complications. I think something I learned early on, and I try and emphasize to people who don't do a lot of surgery, is the only way not to have a complication when you do surgery is never to do surgery. And so we've really spent a lot of time talking about some complications today. And it's always scary to have complications, but I think the reality is that if you follow good technique, this particular MMP procedure is faster, has less risk of complications, and I think has overall less potential for catastrophic complications when compared to the other tibial osteotomy techniques. And so I wanted to emphasize that because really with following the good kind of technique and steps, this is a very good, solid procedure with overall very good outcomes. And even in the event where you do have complications, they're almost always salvageable. And so I agree with that comment that, you know, when you have a proximal cranial tibial fissure fracture, it's not catastrophic. It's not a major complication. You can easily recover from that by following regular principles of fracture fixation.
Brilliant. Thanks, Sarah. Just going back to a couple of the slides, some of the small breed radiographs that have got the small breed staples in, they're actually in both cortex, so they're in the caudal and the cranial, which obviously is we're advocating not to do. What would you do in that situation? Would you keep your fingers crossed, or would you go back in for revision if you saw that on your post-op rad?
Yeah, if I saw it on my post-op rads and I had a smaller staple, I would consider going back in and using a smaller staple in addition to that one that was malpositioned. I wouldn't take the other one out just in case you create problems with the exposed holes in the bones. But if there was a chance to put a smaller, a mini staple in that bridged the wedge bone and face a little bit better, I would recommend that, or using a tension band and wire. It's not something that I would absolutely do straight away because we do know that some of these radiographs may not be exactly showing where those holes are made. And so it's possible that you could be getting some compression. So if radiographically I see that there's been good, reasonable pre-compression, even if the staple is malpositioned and engaging the cranial and caudal cortices slightly, I may follow that radiographically to see what happens with it. Not everyone requires immediate surgical revision or intervention. So it's a toss-up. It's difficult to say. It'll have to be the individual case that I would see. If you had to do something immediate, I would say put a smaller staple to try to prevent that other one that has a greater potential for loosening.
Okay, brilliant. Just kind of on the staple, there's been a few questions asking about the mini staple, and people asking about the drill bit size. So we've done a fair few cases with the mini staple, and it's 1.5 millimeter thick, and it will require a 1.5 millimeter drill bit.
Yeah.
So obviously we'll also need a new staple pin and a new staple drill guide for it. So for those of you asking, they currently are being manufactured, and hopefully towards the back end of next month, we'll have some to get out there to people. So 1.5 thick for the mini, 1.5 drill bit, as opposed to the standard staple that's 2 mil and the small breed staple that's 1.6 mil. Okay, that's that.
Carry on from both those questions. I think this is a testament to Orthomed, the team approach. It's the users and our clinical feedback that is valuable to Orthomed as a company. And if we give clinical feedback, which they encourage, that they want us to do, then that clinical feedback goes back and helps to evolve the technology. And so just as any technology has to evolve, Orthomed really values our feedback, welcomes it, and actually encourages it, and it helps us evolve the system. And so a lot of things discussed today are a consequence of evolution over 50,000+ cases. And so the original question of, a big staple in a small bone shouldn't happen moving forward, because we should have staples that will, be available, appropriate staples available for almost any size of bone going forward.
Brilliant. Yeah, absolutely. Bruce, you mentioned tibial thrust will improve at the end of surgery, but will there still be some cranial draw afterwards?
Yeah, almost always there's cranial draw. Even months later, you may still have cranial draw. The goal of the MMP procedure, such as the TTA, is to eliminate those tibial shear forces to try to prevent cranial tibial thrust. And so when it's performed appropriately, that's what you get, is loss of that, but the cranial draw is still there. And cranial draw is not something that is a passive laxity to the limb. It's active laxity that we create with our hands in so doing, but it's not something that the patient mechanically experiences while they're ambulating.
Yeah. Okay, wonderful.
Bruce, can I just ask a quick question here? I know in similar teachings when we've been in practice together, just doing cases, there is that technique of using the trial wedge to also assess cranial tibial thrust. Can you explain that to everybody on here? Because I don't think that everybody might be familiar with that as well.
Yeah, so while you have your trial wedge in place, you can apply a clamp across the cranial and caudal aspects of the tibia temporarily to hold the trial wedge in place to determine if you have the appropriate size wedge that you're intending to insert as your final implant. So once you have the trial in place, you put the clamp across so it's held in place, and then you can take the knee out of flexion, put it in extension, and then perform the cranial tibial thrust maneuver by extending the knee and flexing the hock at the same time. And if you have tested that before surgery and there was cranial tibial thrust, and now you're testing it with the trial in place and there is no more tibial thrust, then you probably have arrived at the appropriate size implant that you're choosing for the trial wedge that's in. Sometimes Charles will send me patients radiographs where practitioners are looking for some assistance with sizing of the MMP implant, and I will tell him this patient could probably do with either a 9mm or a 10.5mm wedge. So I will tell him to start with templating or putting in a 9mm wedge, testing the cranial tibial thrust. And if there's no thrust with the 9, stay with the 9. If there's a question that there's still a little bit of a few millimeters of movement, then step up to the 10.5 instead. And so the trial wedge can be used to our advantage before you open and put in the inappropriate sized implant. And as I said, if there's any question, the extra 1.5 millimeters of advancement should not be deleterious to the patient. And so if there's a question between a 9 and a 10.5, I would always step up to the 10.5 if the bone can take it. There was one patient that I have regrets on now. It was the only 15mm that I ever put in a dog, and I should have stopped at 13.5. But I didn't stop at 13.5 because I didn't have a 13.5 wedge in-house. I had a 15 and a 12. So I probably should have stopped at 12, but when I got to 12, there was still thrust. And so I put the 15 in, and that dog went ahead and actually ruptured its patella tendon. And so post-operatively, I could see that that dog's patella was dragged very far distally into the joint, severe patella baja afterwards. And so that's one where I probably went too far with that. And it was 3 millimeters instead of 1.5 millimeters beyond where I should have gone. So word to the wise, even very experienced surgeons could have severe complications too. So this is a practice.
Brilliant, thanks, thanks, Bruce. Here's a bit of a, could be a bit of a meaty one. Any comments on the Butcher study showing fluoroscopic tibial thrust more noticeable in TTA patients than TPLO?
I have to say that I don't know the specific details of that paper, so I will defer it to Sarah if he does. But, having some residual tibial thrust, is that what you're saying?
Yes.
Yeah. So yes, we do know that there is residual tibial thrust in TTA patients. Almost in every single case, there is always some residual tibial thrust. I can't say that whether or not it actually contributes to mechanical disease or complications after surgery has not been definitively shown. But as I said, I'll defer to Sarah if he has a strong feeling on that.
No, I agree with that, Bruce. I don't know the details of that particular study either, but I guess for me, this is more of a clinical versus a theoretical issue. And I think we all recognize that cranial drawer doesn't go away. That's something that we contrive. Cranial tibial thrust still exists to some extent, but whether that's really a clinical event or something that we're attributing to be, clinically relevant, I don't know. And
Yeah.
so I would argue that clinically, it has very little impact.
Yeah. Yeah, I mean, I couldn't put a degree on there. We do know that even in this most recent study by out of Germany, it showed that these MMP patients don't get back up to normal or pre-injury state as you may see the TPLO patients do. So maybe the TTA technique is less likely to have a normal clinical function of the limb the longer time goes on compared to something like the TPLO. But improvement in weight bearing has been shown. And if we're comparing 93 to 96% to 89 to 90%, I'm not sure if it's that clinically relevant. But what you do find in the lab versus what you see clinically in the dog may be different. So it's hard to say.
Okay, that's good. That's great. Thank you. Quite a few people have been in touch about your staple guide, Bruce, the one that shows the mini, the small breed, and the standard, and kind of where to put it and where not to put it. For those interested, yes, we are going to just redefine it and just kind of neaten it up a little bit, and then without a doubt that'll be available for everyone to have, and we'll let you know when that's available. It's certainly a useful document. Just a couple of last things. These are individual cases, so it may be that we have to look at these separately and ask for a few more details from the surgeon. I've had a few that seem to have a knockoff femur on tibia, with each step noted pre-op, which doesn't always go with the SX or with the surgery. This is not meniscus click, but a louder audible knock. It's fine, but I wonder long-term joint health is problematic. Any idea what the cause could be and how to intervene? I presume we'd probably need more details for that one, would we?
Yeah, I think palpating the limb while the patient's standing and palpating it in lateral recumbency while they're awake would be helpful to know what exactly the knock is happening. I've seen some TPLO patients in particular have more proximal internal rotation instability, and as a result, some of them will develop a pivot shift. I've not seen pivot shift the MMP or TTA technique, but I couldn't exactly say. Obviously, the other type of pathology that's similar to that has occurred in dogs where I've done a caudal hemimeniscectomy on them, and there is a cranial translation of that tibia with respect to the femur, and I think it's actually the femur sliding off the back of the half of meniscus that's still left behind, and that tends to go away after a while. It may take several weeks, but it's hard to know exactly on that particular patient. Sarah, do you have any clinical impression about?
I can't speak for this specific case, but the other thing that I've found occasionally, but again, particularly with TPLOs and rarely with MMP type techniques, is soft tissue, basically ligamentous tissue, soft tissues that are sliding over the implants that can create a click. And again, I think that's more often associated with the pivot shift type positioning. But typically, they're non-painful. It doesn't alter effusion or have these soft tissue swelling, so it's more of something maybe the clients notice or we notice on palpation, but rarely have I ever noted it to be of clinical significance.
Okay, I mean, and just to any surgeons that have asked these questions or anybody else, you can send those in individually to info@orthomed, and we'll spend a bit more time looking at those individually and get back to you. Great last question, the last one of the day. With regarding tibial plateau angle, at what angle would you recommend a TPLO over an MMP?
Since the MMP technique really doesn't pay attention to tibial plateau angles, it's not something that I really look at per se. I will let you know that I do measure advancement in all of my patients. I still plan for an advancement so that I know how much to advance. But what we do know about TTA technique is the higher the angle gets, so much above 35 or so, you start getting into a advancement where it's going to be really challenging to get or to meet that 90-degree alpha angle. And so if the angle starts getting much higher than 35, I would say that I have a pause. I don't say no on MMP, but there are certain TPLOs that I don't do when they get into the excessive angles. So anything above 40 on a dog, I will never do a TPLO by itself. If it's above 40, I usually combine with a CCWO. There are some small dogs with angles that are above 40 that I do CCWO only, and then the MMP sort of fits somewhere in the middle of all of those, anywhere between 25 degrees and 35 degrees, I think are great equal opportunity patients for an MMP as well.
Okay.
I don't know if that helps, but it's a clinical field sort of thing.
No, thanks. I mean, that's it with questions. Thanks ever so much, Bruce. I think Charles and Sarah just wanted to have a bit of a final word.
Charles, let me just say something quickly, if that's okay. Wanted to just acknowledge, Mark, are you still with us?
Yes.
I'm here.
Thank you, Mark. Just from an outsider's perspective, I wanted to mention a couple of things about Orthomed and the Orthomed team. I think that ultimately, the most important people here today are, the participants who've allowed Orthomed to evolve and develop and be very successful. So thank you for your time today. I know this session was long, but we're very grateful for your time and for you being here. Also wanted to acknowledge Simon, Charles, and Mark. Mark, just for a quick 1-minute history, Mark was very successful in the human medical device industry and left and started Orthomed. I think of him as a visionary. I think the philosophy that he created, where, you know, it's not a Me Too company that's copying other medical device companies, but rather a company that's going out there, developing new solutions for our problems and really emphasizing that is important. It's the reason we have unique techniques like MMP and Ridge Stop and SOP. And it's a collaboration between us, the veterinary community, and Orthomed. So have to acknowledge that we're very grateful for that. One last important thing for me is to acknowledge that Simon and Charles in particular are incredibly dedicated to technical and clinical support. And so I would encourage all of you to do what I've done in the past, which is reach out to them when I've had questions or clinical issues arise, because they are a mine of information and they're able to walk us through most issues or potential issues before they become issues. And also to emphasize the value that Orthomed brings by having Bruce and Scott and a whole clinical team behind us. And the goal is really to make sure that they're not just selling products, but supporting us through our evolution of careers and surgical abilities. So wanted to kind of emphasize all of that and thank you for your support of Orthomed, and thank Orthomed for their support of the veterinary community.